Okay, good morning. Can everyone hear my voice? Can everyone hear my voice? Okay, that's great. Welcome to the 27th lecture of Dr. Haider Step 1. Um, in these group of lectures, what we are doing is we are trying to finish neurology from first date 2020. And we are taking a little bit of time trying to read um, all the different types of topics and concepts and trying to master them and apply them in the question format. And hopefully, in a matter of days, we would be done finishing the neurology. And after that, we have quite a little amount of topics left for our organ systems. So that's that. And after that, we would be going to the basic sciences. And after we are done with our session of lectures, the every one of the students who has finished the topics from uh, A to Z can successfully enter the dedicated period and start prepping for their USMLE Step 1 exam. Having said that, are you guys doing the URL questions at home? Okay. So what I am going to do today is I am going to mention names of all the students and try to see how many questions are being done by each and every student for at least 5 minutes. Okay, so I'm going to start here from the bottom, and the first student here is Dr. Yusuf. Okay, Dr. Yusuf, how many questions did you do last yesterday, or how many questions are you doing? How many questions? 20. Okay, good. Then Dr. Hussam, how many questions, Dr. Hussam? Okay, so no answers. So we will keep on moving on. Dr. Lala, 7. Okay, Dr. Hussam, 60. Okay, then we have the next doctor, Dr. Evelyn. Okay, that's very good. That's very impressive. 50 questions. That's very good. Can we, okay, then Dr. Ahmed. Dr. Ahmed. Okay, then the next one is Dr. Uday. Dr. Uday over here. 40. Okay, that's very good, Dr. Uday. Dr. Uday, would you be kind enough to see one of the messages which we have sent you and give us a reply as soon as possible? Maybe by the end of today's lecture. Is that okay, Dr. Uday? Yes, your email. We have sent you a message yesterday regarding some informations. Would you be kind enough to see that and give us a reply by the end of today's lecture? Okay. Okay, perfect. Then Dr. Mon, how many questions? 30 by Dr. Iman. Okay. 15. Okay. 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 So the purpose for asking the amount of questions is simple. That is, if a student is doing less than 30 questions, then then this means that they can give their exams in 6 to 7 months. Okay, 6 to 7 months. If a student is doing questions around 30 to 40, 40 to 60 questions per day, this will allow them to sit for the exam in the next 3 to 3.5 months. Okay, so if you want to sit for the exam a bit sooner, then the amount of questions that you need to be doing should increase drastically. Okay, the amount of questions that you need to be doing should increase drastically. So that's what I meant. Okay. So with that being said, it's 9:20 as of right now, and before we begin on our today's lecture, I wanted to do a quick recap of our neurology because neurology is pretty complicated and big, and we studied quite a little bit of difficult topics yesterday. Okay, so how about we start with our discussions on neurodegenerative disorders? How about that? Is everyone ready? And let's see how far everyone remembers all the things that we have discussed. Okay, okay, perfect. Is everyone ready? Okay, okay. So my first question is, you have a patient who comes to you. Okay, you have passed your USMLE step one, step two. You have entered your residency, and you have scored so well in your USMLE step one that now you are a neuro medicine resident. Okay, you have done your residency in internal medicine. Now you are doing your subspecialty in neuromedicine, and now you have a patient who has come to you with headache, tinnitus, papilloedema, and when you do a CT scan, you see that the CT scan is absolutely normal. What is your provisional diagnosis? What is your provisional diagnosis? Okay. So we have one doctor, Dr. Adhanom. Okay. The pseudotumor cerebri. Pseudotumor cerebri. The another name for pseudotumor cerebri is intra-idiopathic intracranial hypertension. Okay, very good. And can you guys describe the patient profile of idiopathic intracranial hypertension? The patient profile of idiopathic intracranial hypertension. Female tone. Okay. So what are the mnemonics? Okay. Okay, good. Okay, that is very good. Okay. Okay. So now you are doing a nervous state examination. Okay, you are doing a neurological examination in your ward, and you see that you have a patient who is staring at you from a bed. Okay, two beds away, and when you do a quick clap, when you do a clap, the patient starts to have a startle. The patient starts startling. What is your diagnosis? Very good. Very good. I'm so proud of you guys. Very good. Okay. Creutzfeldt-Jakob disease. Creutzfeldt-Jakob disease. Okay. That is very good. If you do a CSF study of Creutzfeldt-Jakob disease, what are you expecting to see? What is the name of the protein in the CSF? You cannot see prions. You cannot see prions on CSF. That is good. So what you're about to see is 14.3-3 protein increase in the cerebrospinal fluid. Okay. Now you have a patient who has long-term chronic hypertension. Now the patient has stepwise decline in cognitive dysfunction and memory. What is your diagnosis? Stepwise decline in cognitive function and memory. That is absolutely brilliant, Dr. Adeno. Vascular dementia. Okay. Okay, to all the doctors who have mentioned vascular dementia. That is good. Okay. How about a patient who has come to you with visual hallucinations and dementia? Visual hallucinations and dementia. Okay, Lewy body. What is a Lewy body? What is a Lewy body? Okay, accumulation of alpha synuclein. Accumulation of alpha synuclein. Okay, very good. And what is the gene that is responsible for accumulation of alpha synuclein? SNCA. SNCA gene. Okay. Okay, good. The next question is, what is the name of the disease? What is the name of the disease in which there is change in personality followed by onset of dementia? So we have change in personality followed by onset of dementia. What is the name of that disease? Okay. So the name of that disease is frontotemporal dementia, or as we would like to call it, pig's disease. What was the mnemonic that we used for pig's disease? Okay, good. Very good. Okay. Okay. The next of the three are very important and very common. Okay. So these are the types of dementias which are difficult to remember because they are not that common, but they are frequently asked in the USMLE Step 1 and they are very high yield. But the rest three are very common and you will see them on a daily basis. Okay. And the rest of the three are Parkinson's, Huntington's, and Alzheimer's. Okay. And I will not go into any more details of the first three disease because they will be very widely asked. If I have to ask one question, then my question is, what is the histological findings of a person who has been diagnosed with Alzheimer's disease? Histological findings. We have a couple of histological findings of an Alzheimer's patient. What are the four or what are the five histological findings? Five histological findings. Number one, cortical atrophy. Number two, senile plaques. Number three, neurofibrillary tangles. Number four, loss of gyri. Number five, ex vacuo, ventriculomegaly, and Hirano bodies. Okay, so five things. Hirano bodies. Okay, good. Okay. Can you guys tell me really quick what are the neurotransmitter changes in Huntington's? The neurotransmitter changes in Huntington's. Okay, good. Okay. Okay, do we have Dr. Mazar Yusuf over here? Mazar Yusuf? Okay, good. Dr. Yusuf, would you be kind enough to check your email? We have sent you an email yesterday. And give us a reply to that email by the end of today's lecture, please. Okay. Okay, perfect. Okay. Okay. So we have a question from Dr. User One. The question is, before we started, I have a question. For some reason, I cannot attend every lecture, and sometimes I can attend only partly because I have to pick my. Okay. but I want to keep on paying it. But my question is about attendance. Again, the lectures I misses with the common groups attending is better than being by myself. Okay. Okay, so Dr. User One, first of all, thank you so much for sharing your issues and obstacles. Okay, so we will help you get past your issues and obstacles so that you can attend your lectures. So what we are going to do is every day, okay, every day we are going to send you guys the lecture recordings. Okay, we are going to send you guys the lecture recordings so that you can stay at home and watch it on your free time. That's not a problem. And at the same time, we have also shared our previous lectures with every one of you. Have you guys received those lectures? Have you guys received the previous lectures that we have sent? Okay. So we have sent all the lectures more or less from lecture number 9 to lecture number 19, and we have sent it out to all the students who has attended the lecture. Okay. So Dr. Khatun, you were not present for those lectures, so we did not send it to you. But for all the students who were present during those lectures, we have sent it out. Okay, and it's not supposed to disappear. It's still there. It's still there because I can still see it as of over here. Could everyone attend the lecture? Could everyone attend the videos? I mean, in Dr. Heidi's step one. Oh, but it disappears. Okay, so does disappear is, okay, what does disappear are the lectures from Zoom. So the thing is, we delete the lectures from Zoom as soon as possible because we need to collect space in order to record the videos. Okay, so we need to collect the space in order to record the videos. So we delete the lectures. That's why we ask you guys to download the lectures as soon as possible. And even if you did not download the lectures, that is still there's still nothing to worry about because we add the lectures to the Google Drive. Okay, so we add the lectures to the Google Drive. So that's what it is. And I know you said that you need lecture number 3 and lecture number 5. Okay, lecture number 3 and lecture number 5. So what we did was yes, the lectures in Google Drive are from lecture number 9 to lecture number 18. Okay. We will still keep on uploading 19 and 20 by today. Okay. Lecture number 9 and lecture number 20. And we will still keep on uploading them. And if you still have any issues with the lectures, sorry, the lectures won't be deleted. No, the lectures will be deleted from Zoom because we need to have space in Zoom in order to record. That's the issue. So we download the lectures and then we upload the lectures on Google Drive. But when we send you guys the lectures, what happens is we need you guys to download the lectures if possible as soon as possible. So that's that. Okay. No, the lectures that is in Google Drive, they will not be deleted. So there's nothing to worry about. Okay. 16, 17 were missing. Okay. 16, 17 were missing. Okay. If 16, 17 were missing, then okay, then we would look into it and then we will add it again. No problem. Okay, we will add it again. No problem. Okay, we apologize. I know you guys have been asking us for the videos for a long time right now. Okay, we have Dr. User One who has been asking for the videos for a long time. Okay, but the thing is, there are multiple things that we have to do during our day because this is only our part-time job. So the thing is, we did not plan on sending the lectures to any one of you. Our only plan was to take the lectures. Only when we started getting requests that we should get the lectures so that we can stay at home and watch it, that's when we decided on sending the lectures out. So since we had a change in our plannings, that's why it's taking us a bit of a time. I hope each and every one of you would understand, and thank you for your patience in order for allowing us sometimes to keep up with your requests, and hopefully we will. Okay, we apologize for the delay, but having said that, okay, none of the lectures will get missed out. Every one of the lectures will get added. Okay, is that okay? Can we? Okay, thank you so much for giving us that time. And do not worry, every one of the lectures are there. And we are also here for you all the time. So you have nothing to be worried about. If you need the lectures, and even if the lectures are not there, if there is one single topic you need us to discuss, we are more than happy to discuss it again with you. Okay? If there is a single topic which all of you decide to discuss once again for revision and recapitulation, we are absolutely more than happy to discuss it with you. Okay, so that's that. Okay, having said that, can we move on with our discussion? Okay, good. Okay, okay. So I wanted to talk about some of the movement disorders. Okay, some of the movement disorders. I want to talk about movement disorders. First of all, if you have a patient who comes to you with restlessness and intense urge to move, what is the name of that moving disorder? You didn't answer my question. Okay, Dr. Usmle, let me go back to your question once again. Okay, 1 second, guys. One more question before we move on. Okay, so once again, for Dr. User One, do you want to keep on attending the lecture or do you want the recordings every day? So how can we help you guys? How can we help you out? If you can please rephrase your question, I would appreciate that. How can we help you out? So we can provide you the lectures every day, which we already do. What else can we do to to make your obstacles easy
Uh,
for you?
Sorry, for the next upcoming,
Can we put
you
you
know,
on? Can we put you on a quick mute and use the chat box, please? Just for now. Okay. Thank you. Okay. So what? How can we help you out? Okay. So we are more than happy to help you out with any obstacle that you are going with, you are going through, and we can work around them. So we can provide you the lectures every day if you want, or we can we can provide you the week's lecture ahead, or what can we do? Okay. Oh, okay. So you want to attend the future classes with the next group? Is that what it is? Okay, I understand. Okay, so you want to attend the future lectures because right now you are busy with your obstacles. Okay, I understand. Okay. Okay, so the thing is, you can do that too. That's not a problem. Okay, but the thing is, by the so after we are done with our organ system, and then we will move on to basic sciences, right? And then we will move on to basic sciences. It will take us quite some time to come back all the way. I understand because you are going to miss some lectures. Okay, I finally understand. Thank you so much. But the thing is, so my answer is, we are more than happy to come and ask you to join the lectures once again, since you are busy right now. Okay, so what would happen is, after we are done with neurology, we will keep on moving on. We'll go to psychiatry, nephrology, and then reproductive systems. Okay, so and after all of that, we will not be coming back to discussing the organ systems again. We will be going back to the basic sciences, okay, so that we can finish the 3 month session. And after the 3 month session ends, then we would come back again and start studying from CVS. And by then, it might be, you might fall a little bit behind. I'm not going to lie to you because it will take us quite some time to finish everything and then start from once again. Because for all the students who has joined the lectures in the mid, the initial lectures for the initial lectures of the organ system, they were not there. So we have to do the lectures for them once again. Okay. So my best advice to you is, so first of all, it's not about the transactions. Okay, the transactions are not important because we have students over here who have asked for extensions, and okay, so don't worry about don't worry about the transactions. First and foremost, do not worry about the transactions. The second thing is if you the best advice I can give you is if you can keep up with us, okay, if you can, let's say, get done with let's say, for example, the transactions on Monday or Tuesday, okay, what we can do is instead of asking you to come and join the lectures, we can directly send the lectures to you, because we have students who access our lectures from home because they cannot match our timing, and then they keep the lectures, and then they make the folders where they keep and store our lectures, and then they watch it by themselves when on their free time. Okay, so that's what you can do. That's my best advice to you. So what happens is you can keep on doing that until the point when you get free, when you have free time on your hand and you are confident you can come and join the lectures again, then you can come and join our lectures. If that's that's the best advice I can give you right now. Is that something that did that help? So was that helpful? Okay, so make sure that you tell us that you want to continue with us via email, and what we will do is we will send you the lectures via email after we are done with every day's lecture. That's it. Okay, so that way you can keep up with us, and you can store the lectures, and then you can watch it later when you get your free time. Okay, do we have any more questions before we move on? Do we have any more questions before we move on? Okay, so we only have some time to start. Okay, so before we start, I just want to do a quick revision of previous chapter, and then we can move on. Okay. Okay, so can everyone see my screen? So can everyone see my screen? Okay, good. Okay, so what I am going to draw over here, are the boxes for aphasia. Okay, so, okay, okay, very roughly, very roughly. Okay, what do I have to write over here? Okay, over here. Okay, over here. Okay, over here. Okay, good. Over here. Okay, over here. Okay, over here. Okay, over here. Okay. Over here. Okay, over here. Okay, so these are your boxes. Okay, good. Good. Okay. Very good. Okay, that's very good. Okay. So, okay, so this is a very important box which you have to master, and I'm pretty sure by what you have just answered and how much you have answered, I'm pretty sure you guys have already mastered these boxes. Okay, and the next time you get a question from aphasia, have you guys received a question about aphasia as of yet? Aphasia? Yes. Okay. When you when you have received a question from aphasia, have you been able to draw the box? Anyone? Have you been able to draw the box? Okay, and did the drawing of the box help? Okay, so it gets easier when you draw the box. Okay, okay, good. So it helped you very much. That is great. Okay, so it's 9:45 as of right now, as every day. So we are done with our discussion and revision and recapitulation and questions about Usmle and the lectures and everything. Okay, more or less. If we have any further questions, we will keep it to ourselves for now, and we will answer them and ask them at the end of today's lectures. Okay, so that's that. Okay. So having said that, let's start with our today's lecture. And for today's lecture, what we are going to discuss is we're going to discuss a very important demyelinating disorder. And that the name of that disorder is multiple sclerosis. The name of the disorder is multiple sclerosis. Okay, so what is multiple sclerosis? Basically, what do you mean by demyelination? Demyelination basically means loss of myelin sheets. Okay, demyelination basically means loss of myelin sheets. And if there is demyelination, we talked about some of the things that will change. Can we mention very fast about some of the things that will change in a nerve if it's demyelinated? Can we talk about the time constant, and can we talk about the space constant? What will happen to the time constant and what will happen to the space constant? Okay, so time constant will increase, space constant will decrease. Okay, so that's what it is. Time constant will increase and space constant will decrease. Okay, so right now, what is multiple sclerosis? Multiple sclerosis, at first, it's an autoimmune inflammation and demyelination of the CNS, okay, with subsequent axonal damage. Okay, so multiple sclerosis, first of all, multiple sclerosis will get stars. How many stars will it get? How many stars will multiple sclerosis get? For me, multiple sclerosis will get 2 stars. Okay, it will get 2 stars. Not only do you have to know and answer questions regarding multiple sclerosis, you have to differentiate this from all the other demyelinating disorders. So it's an autoimmune inflammation and demyelination of CNS with subsequent axonal damage. It presents with 4 things basically. First of all, there's acute optic neuritis. Okay, so what happens is there is unilateral vision loss with Marcus gun pupil, and I will tell you what Marcus gun pupil is in 1 second. Okay, but first of all, there is acute optic neuritis. Okay, then the next one is your brain stem or cerebellar degeneration. The next one is your brain stem or cerebellar syndromes, that is diplopia, ataxia, scanning speech, intention tremor, nystagmus, and internuclear ophthalmoplegia. Okay, so all of this is happening because the white matter has lost its myelin cover. Okay, and basically in the multiple sclerosis, it affects the white matter of the central nervous system, and we know that the white matter of the central nervous system is myelinated by oligodendrocytes. So there's loss of oligodendrocytes, which leads to these signs symptoms. Next one is pyramidal tract demyelination. So there's demyelination of the pyramidal tract, once again, a CNS white matter. And this demyelination leads to weakness and spasticity. Another one is spinal cord syndromes. Okay, spinal cord syndromes are shock-like sensations. Okay, that goes from the neck all the way to the spine. Patients also get neurogenic bladder. There's paraparesis, sensory manifestation affecting the trunk or more. Okay, so what will we do? First of all, okay, so there are these things that you have to remember about. There are these things that you have to remember about multiple sclerosis. So we will try to incorporate these things in a diagram basis. Okay, so this is your patient. Okay, so this is your patient of multiple sclerosis. So the first thing okay, so this is multiple sclerosis. Okay, so very roughly drawn, what are the sign symptoms? First of all, okay, so swollen eye, or meaning painful eye, acute optic neuritis. Okay, then what happens? Then this hand, okay, okay, shaking hand for intention, shaking hand for tremor. Okay, tremor. Okay, so if a patient has tremor, intention tremor, then all the other cerebellar, okay, cerebellar sign symptoms are there. So we just drew two things. We drew a swollen eye, and we drew a tremoring hand. Okay, we drew a tremoring hand. Okay, next one. Next one is what else? What else? Okay, so what else over here? Okay, so we will draw the patient's bladder. Okay, we will draw the patient's bladder over here. Okay, and the, the okay, and okay, so weak bladder. Okay, so neurogenic bladder. Neurogenic bladder for spinal cord demyelination. Okay, we will use the neurogenic bladder over here to make us remember that in multiple sclerosis, you have spinal cord demyelinations. We will use the tremor to help us remember that in multiple sclerosis, you have um, cerebellar demyelination. Another thing that happens is this leg over here. Okay, we will draw this flaccid leg over here. Okay, this leg will show some amount of flaccidity, and this flaccidity will show that it's weak. So weakness. Okay, and weakness of the leg, weak leg for pyramidal demyelination. Pyramidal demyelination. That's what it is. So four things that we have to consider. Number one, acute optic neuritis. Okay, acute optic neuritis, painful unilateral vision loss with Marcus gun pupil. Number two, tremor. Tremor will help us realize that these are cerebellar. There's demyelination of the cerebellar tracts. Okay, cerebellar tracts. Once again, can we have a quick recapitulation of the cerebellar tracts, please? The peduncles, the superior, middle, and inferior peduncle. What is responsible for the inferior cerebellar peduncle? Inferior cerebellar peduncle. Okay, good. Okay, so you guys remember. Okay, so that's what it is. Okay, so acute optic neuritis, tremor for the cerebellar demyelination. Along with tremor, you can also expect your patient to have ataxia, diplopia, and scanning speech. Okay, and nystagmus. And then after that, you have neurogenic bladder for spinal cord demyelination. And this is number three. And for number four, you have weakness and spasticity, or weakness or spasticity of the pyramidal tract. Okay, so this is not flaccidity, this is spasticity. So weakness or spasticity, this will indicate that this patient has pyramidal tract demyelination. So basically four things. So I would expect you guys to draw something like this on your book so that it's easy for you. So that next time when you see the text, you can easily see the drawing and you can associate the sign symptoms. Did you guys draw the features? Did you guys draw it out? Okay. Okay. Keep in mind that this is one of many. Okay. The tremor is, there is not only tremor, there's ataxia, diplopia. There's not only neurogenic bladder, there's also electric shock-like sensations from the neck to the spinal cord. And there's not only weakness, there's also spasticity. So these are just some of the things for multiple sclerosis. Okay. Next one. Next one is I wanted to tell you guys what the Marcus gun pupil is. The Marcus gun pupil is basically the term which we said to an abnormal pupil, which shows pupillary response at certain ocular disorders. It literally means that the Marcus gun pupil means that there's a relative efferent pupillary defect. Okay, so that's what it means. It means that there's a relative efferent pupillary defect. So what happens is after exposure to a bright light, okay, after exposure to a bright light, the pupil, they usually it usually constricts. Okay, the pupil, they usually constrict. But in case of a Marcus gun pupil, um, if you move, let's say if you move the light, from the affected pupil to to the unaffected pupil to the affected pupil, what would happen is there will be no pupillary constrictions, there will be pupillary dilatations. Is that clear? So normally what would happen, there will be pupillary constrictions, but in case of a Marcus gun pupil, when you show bright light to the pupil, there will be pupillary constriction, not pupillary dilatations. Are we clear? Are we clear about Marcus gun pupil? Okay. Okay. Marcus gun pupil. Marcus gun pupil is, let's say you have this eye, then you have this eye. Okay. This is the affected eye. Okay. This eye is affected by multiple sclerosis. Okay. So what happens is if you shine light into this eye, there will be pupillary constriction and there will be pupillary constriction. Okay. But if you shine light into this eye, okay, there will be pupillary dilatation and here will be pupillary dilatation too, because this is the affected eye. So this affected eye is known as the Marcus gun pupil. This is due to demyelination of the optic nerves. Okay, are we clear? Okay, so that's that. Okay, so that's what it is. Okay, next one. Next one is so the symptoms are, so the basically these symptoms, they're exacerbated by hot bath and exercise. Okay, and out of all the different types of multiple sclerosis, the relapsing and remitting type is most common. Okay, the relapsing and remitting type is most common, and basically it affects women in their 20s to 30s. So the epidemiology of the disease is women in their 20s and 30s. So that's what it is. So women in their 20s and 30s. That's that. Okay, so what are the findings? The findings are basically you have increased amount of IgG level and myelin basic protein in the CSF. Okay, so if you do a CSF study, you have increased IgG level. Why is the IgG level increased? Can anyone tell me why the IgG level is increased, please? Why is the IgG level increased? Can everyone hear my voice? My question is, why is IgG increased? Okay, so it's an autoimmune disease. That's why the IgG is increased. Okay, because it's autoimmune. Okay, next one. So what happens is IgG is increased, and you can also see a protein known as myelin basic protein over here, and the oligo and out of all of this, okay, if you see bands, okay, if you see bands which are oligoclonal, so oligoclonal bands, and you see oligoclonal bands, and these bands are protein bands. Basically, protein bands could be monoclonal or oligoclonal, and if you see oligoclonal bands over here, then these are diagnostic of these are confirmatory diagnosis of multiple sclerosis. Okay, so that's that. Okay, okay. So and there are more things that we can see. There are more things that we can see. First of all, if we do not want to do an invasive procedure, if we want to do a non-invasive procedure, what we can see is if we can do an MRI, okay, if we do a magnetic resonance imaging of spinal cord, what we can see is there is these type of image of the brain in which you will see that there are periventricular plaques. So these are the ventricles. Okay, so this is the lateral. These are the two lateral ventricles over here, as you can see, and these are the plaques. Okay, so these are the plaques. Okay, so and the presence of periventricular plaques. Okay, the presence of periventricular plaques. The reason why this is happening is because what happens is in the white matter. Okay, so you have these oligodendrocytes, okay, which are surrounding the white matter. And if there is damage of the oligodendrocytes, there is reactive gliosis. Okay, there is reactive gliosis of the white matter. And when there is reactive gliosis of the white matter, what happens is there is some amount of scarring. And when you have scarring, you also have some amount of calcium depositions, and this results in this plaque-like lesions, and these are known as periventricular plaques, and these are highly diagnostic of multiple sclerosis. Okay, and how do we treat a patient with multiple sclerosis? First of all, we have to, since it's a very progressive disease, okay, since it's a progressive disease means that we have to stop the progression. How do we stop the progression? We stop the progression by drugs such as beta interferons, such as glatiramir and natalizumab, okay, glatiramir and natalizumab. And these are some of the drugs that we can remember. Okay, so first of all, are you glad that there are drugs that is being made to treat multiple sclerosis? Yes or no? Because if there were no drugs, then we could have possibly died. Okay, so are you glad? Okay, so you are glad. So the name of the drug is Gladiramir. Okay. Okay, glad you remember. So you are very glad that you have drugs that can treat multiple sclerosis. Okay, so our gladness is forecasted in the name of the drug, that is Gladiramir. Okay, that is brilliant. Next one is, do you remember I talked about a friend, one of my friend whose name was Natalie, and Natalie had multiple sclerosis. Yes, no. Do you guys remember about my friend Natalie who had multiple sclerosis? No? Okay, so now you know. Okay, so I have a friend called Natalie who has multiple sclerosis. Okay, okay, you do not remember because I have not talked about her. Okay, but right now I am. So my friend, I have a friend, her name is Natalie. Natalie has multiple sclerosis. Okay, so, and the drug which can be used to treat my friend is basically the same drug which goes by her name. So the name of that drug is natalizumab. Okay. So first of all, we are glad that we have treatments for multiple sclerosis. So our first drug is Gladiramir. Okay, Gladiramir. And another one is about my friend Natalie, who has multiple sclerosis. And the drug that is being used to treat my friend is astonishingly the same thing which goes by her name. And that is natalizumab. And it's important that you remember these informations because you will be tested on this on USMLE Step 1. Are we clear on natalizumab and Gladiramir? Okay. Another thing that we can always use to treat an autoimmune disease, okay, is the father of an anti-inflammatory medication. Okay, does anyone know which medication I'm talking about? Father of anti-inflammatory medication, very good, steroids. So IV steroids. Okay, we can also treat them for IV steroids. Okay, now if you have a patient with neurogenic bladder, okay, you can treat neurogenic bladder by either catheterization or muscarinic antagonists. Okay, by catheterization or muscarinic antagonist. Another thing that you can use is if the patient has spasticity. Okay, if the patient has spasticity, what we can do is we can also use muscle relaxants. We can also use muscular relaxants such as baclofen, GABA. Okay, and for pain, we can use TCAs. Are we clear on the specific treatment? Okay. So first of all, specific treatment. Specific treatment are, I'm glad there is a treatment. So Gladiramir, and my friend Natalie, who has MS, so natalizumab, and IV steroids. Okay, and the rest are your symptomatic treatment. Symptomatic treatment. Symptomatic treatments are treatments for neurogenic bladder. Okay, treatment for neurogenic bladder are by catheterization, muscarinic antagonists. Okay, and then we have uh, spasticity, for which we use baclofen and GABA, right? And for pain, we use TCAs. TCA. Which pain are we talking about? Which pain are we talking about in MS? Fast answers, please. Can we get some fast answers? Which pain are we talking about? Optic neuritis. Correct. Correct. That is absolutely correct. Okay. Optic neuritis. That is correct. Okay. Now, can I give you guys 1 minute? Okay. Can I give you guys 1 minute after this? I will move on to the next ones. Before that, I have to understand you guys have understood multiple sclerosis. Okay, so what I'm going to ask you the questions, and any one of you will give me the answers. Okay, instead of wasting time, let's just ask you the questions, and you guys can answer all together. First of all, okay, first of all, let's talk about the signs symptoms once again about multiple sclerosis so that we can move on because we have successfully finished a very important thing. Okay, so first of all, what are the presentations of multiple sclerosis? What are the presentations of multiple sclerosis? Okay, then, okay, neurogenic bladder, okay, then, okay, then, okay, okay. So how will you receive questions about multiple sclerosis? Multiple sclerosis, you will receive multiple questions where they will tell you that you have a patient who has come to you who is a female patient in their 20s to 30s with acute onset of unilateral pain, pain in the unilateral eye, along with visual loss. And the patient also has weakness or spasticity, or they will talk about neurogenic bladders, that the patient has a neurogenic bladder or the patient has urinary incontinence. Okay, so this is how they will describe the disease. And if they describe the disease and if they ask you what are the CSF findings, what are your answers, please? CSF findings of multiple sclerosis. What are the things we'll see? Oligoclonal bands and and IgG and okay, okay. And if they do not want to do an CSF study, what is another non-invasive procedure that we can do? And what do we see in the MRI? What will we see in the MRI? Okay, periventricular plaques. That's what it is. Okay, so we will see periventricular plaques. That's what it is. Okay. Okay. Next one. Next one is osmotic demyelination syndrome. Okay, the next one is osmotic demyelination syndrome, and it is also known as central pontine myelinolysis. Okay, so central pontine myelinolysis, and I talked about this before that if you infuse a hypertonic solution very fast in a patient, then they will get a condition which is known as they will get a condition that is known as your osmotic demyelination syndrome or central pontine myelinolysis, in which there will be demyelination, right? So what happens is there's a massive demyelination in the pontine white matter, okay, in the pontine white matter. Now, what are the okay, what are the cranial nerves that goes above the pons? Fast answers, please, because we do not have a lot of time. What are the cranial nerves that goes above the pons? Very good. Very good. Okay, and so you guys understand that the cranial nerve that goes at the level of the pons, okay, they will undergo demyelination, and also the white matter that goes, I mean, the pyramidal tract that goes through the pons will also undergo demyelination. So the patients will have quadriplegia, severe quadriplegia. Okay, so there will be axonal demyelination in white matter, secondary to rapid osmotic changes. Okay, so what happens is, okay, let's say that let's say that this is okay, okay, that this is the oligodendrocyte, okay, and let's say that this is a hypertonic solution in the surrounding fluid. Now, if we have hypertonic solution in the surrounding fluid, the fluid inside the myelin will leave the myelin. Okay, the fluid inside the myelin will leave the myelin. This will lead to shrinkage. Okay, this will lead to shrinkage, and eventually the myelins will die, and this will lead to demyelination. Okay, so by this process of demyelination, what happens is, by this process of demyelination, what happens is the patient, they come up with demyelination of the white matter, okay, and then they have acute paralysis, dysarthria, dysarthria, dysphagia. And why are they having dysarthria dysphagia? Because at the level of the pons, we have the cranial nerves, which are responsible for your deglutition and talking, right? Then they will have diplopia, okay, and that's the thing. So basically what happens is you are locked in. So this can cause locked in syndrome. What is the name of the artery that can also cause locked in syndrome? What is the name of the artery that can cause locked in syndrome? Basilar artery. Okay, basilar artery. Okay, so let me show you guys a quick video so that we understand. Okay.
So he can't swallow because we've got angry and getting his mess and it's and again, check it out. Boy. He's even he's smiling too. See, he's in heaven right now.
Okay, so this guy over here, do you guys see this patient over here? So this guy has been diagnosed with locked-in syndrome, and with eventual regular exercise, they are trying to regenerate the nerves. Okay, but it's of very little value because it takes a long amount of time for the nerves to regenerate. But do you see how unresponsive the guy is? The only thing that the guy can do is move their eyes. Do you see this?
He's just destroyed his body and he's loving every minute of it. Having that each for the next show.
Okay, so this guy is doing pretty well. But do you guys, but you guys get the idea, right? So you guys get the idea that that's what basically locked-in syndrome is. So basically, this guy is suffering from a locked-in syndrome, maybe from a medical malpractice. So that's what it is. So always remember that when you do when you treat a patient with hyponatremia and you infuse hypertonic solution, okay, let's say 3% sodium chloride, 3% normal saline, okay, make sure that you do the infusion extremely slowly so that your patient does not get demyelination, okay, because this will be very unfortunate for both the doctor and the patient. Okay, we're done talking about this. Okay, and this one over here shows demyelination. Always remember, demyelination is represented by this white thing over here. Okay, so there's demyelination is represented by white. Okay, that's that. So even in MS, you had demyelination, which was represented by this white things over here, because along with demyelination, there's deposition of calcium, which turns the images white. So that's that. Okay, next one. Next one is a very common disease, and we have all heard a little bit about Guillain-Barré syndrome. Another name for Guillain-Barré syndrome is acute inflammatory demyelinating polyradiculopathy. Okay, acute inflammatory demyelinating polyradiculopathy. And what happens in Guillain-Barré syndrome is you have, whenever we hear about Guillain-Barré syndrome, we instantly think about a very famous bacteria, that is Campylobacter jejuni. But we also have to remember that there are some other microorganisms too. For example, over here you get a lot of questions regarding Zika virus. So the Zika virus, okay, and Zika virus and Campylobacter jejuni, both of them are associated with causing Guillain-Barré syndrome. Okay, so what is this condition? This basically is a condition in which there is some amount of molecular mimicry. There is some amount of antigenic mimicry, and the antibodies that are produced against Campylobacter jejuni and Zika virus, they mimic the same antibodies that are formed against the antigen of Schwann cells. So what they do is the Schwann cells are the cells that myelinate the peripheral nervous system. So what they do is they go and attack the Schwann cells, and there's demyelination of the motor fibers, sensory fibers, peripheral nerves, okay, including the third to 12th cranial nerve. Okay, including the third to 12th cranial nerve to some extent, but majority is there's demyelination of the peripheral nerves. Okay, and they are facilitated by molecular mimicry, as I just said. So the antigens. So first of all, if a patient gets infected with Campylobacter, there will be formation of antibodies against that Campylobacter antigen, and that antibody will go and attack the antigen of the Schwann cells. Okay, so that's it. And what would happen is you would have ascending paralysis. Okay, there will be symmetric ascending paralysis, meaning what would happen is, let's say there's your patient over here. Okay, okay, there's your patient over here. The paralysis will start from the legs all the way. It will keep on going up, 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 up. And if you cannot stop the paralysis, then if it affects the diaphragm, the patients will have respiratory failure and the patients will die. So we have to stop this ascending paralysis right away in order to save the patient. And what would happen is the patients would have absence of deep tendon reflexes. Okay, and if, okay, let me just, okay. So there will be ascending paralysis, and if the patient can, if we cannot stop the paralysis, they will go and affect the diaphragm. Okay, and if we cannot stop that, the patient, what this will do is, if it affects the diaphragm, there will be respiratory failure. There will be respiratory failure. Okay, and but fortunately, this is very controllable. Okay, so first of all, if you suspect your patient to have acute inflammatory demyelinating polyradiculopathy or Guillain-Barré syndrome, we do a CSF study. Okay, CSF study, and if we do a CSF study, we see that there has been an albuminocytological dissociation, meaning that there is an increased amount of albumins in the CSF compared to all the other cells, and that is very highly unlikely because the albumin level in the CSF is usually not that high. In case of Guillain-Barré syndrome, the albumin levels will be extremely high. And if you have confirmed Guillain-Barré syndrome, the most common treatment that we use is IVIG, meaning IV immunoglobulins. And what happens is these IV immunoglobulins, what they do is they go and bind to the antibodies that are produced against the Schwann cells, and they go and they deactivate those antibodies. Okay, so those antibodies can no longer go and attack the Schwann cells, and as a result, the progressiveness of the disease, it stops. And there is another thing that we can also do is we can also do plasmapheresis. Okay, so we can also you do plasmapheresis, but always remember that for this one, since it's not an since it's not a sporadic onset of autoimmune disease, let's say multiple sclerosis has no inciting antigen, okay, so we can use steroids for multiple sclerosis, but this is initiated by an infection. So we have Campylobacter or Zika virus. So whoever has Guillain-Barré syndrome has also an infection, and we never use steroids in infection because steroids during an infection will flare up the disease. So we have to stay away from using steroids. So that's something we have to be careful about. So no role for steroids. Okay. So no role for steroids. Okay. So that's that. And so how will you receive questions about Guillain-Barré syndrome? Your questions are basically going to come from over here at the presentations, and your answers are usually the name. Okay, the answers are usually the name. Okay, so basically what you will have is you will have a patient who has come to you with sudden onset of flaccid paralysis of both limbs. Along with that, the patient has absence of deep tendon reflexes, and the patient will have a past history of being infected or having diarrhea. Okay, so onset of paralysis with a history of diarrhea, the first thing that should come to your mind is Guillain-Barré syndrome. This is not that hard to imagine Guillain-Barré syndrome. That's exactly what would happen. And the paralysis is symmetric ascending paralysis. And the treatment is, what is the treatment once again for Guillain-Barré syndrome? Fast answers, please. What is the treatment? What is the treatment for Guillain-Barré syndrome? IVIG and plasma freeze. Can we use steroids? Yes or no? Can we use steroids? Yes or no? Okay, so make sure the guys not use steroids. What do we find in the CSF of Guillain-Barré syndrome? CSF? What do we find in the CSF? Okay. Okay. And then what do we find in the CSF of multiple sclerosis? What do we find in the CSF of multiple sclerosis? Oh. What do we find in the CSF of Creutzfeldt-Jakob disease? Creutzfeldt-Jakob disease. Okay. Down in your book. Okay. Okay. 1 second. You also have another CSF finding. Okay. Okay. What do we find in the CSF of subarachnoid hemorrhage? Okay, so write these down, the CSF findings, okay? CSF for subarachnoid hemorrhage, CSF for GBS, CSF for MS, CSF for CJ. Write this down so that you can never get confused about the CS findings. Okay, so that you can just look at a glance, you can just look at a glance about all the CSF findings and you can answer your questions accordingly. Okay. Okay, next one. Next one is a very easy one to understand. This is known as acute disseminated or post-infectious encephalomyelitis. Okay, so basically there are multifocal inflammation and demyelination after an infection or vaccination. So if anyone gets infected or if anyone gets vaccinated, you will get you will get a very uncommon condition, and this uncommon condition is known as disseminated encephalomyelitis. Okay, and how can you diagnose encephalomyelitis in your disseminated encephalomyelitis in your exam? First of all, this could be a diagnosis of exclusion. First of all, if nothing goes with the question, then your answer is this one. Another one is if they specifically mention that there has been a history of vaccination followed by spasticity, weakness, neurogenic bladder, okay, and all of these onsets have happened after the patient was vaccinated, then you have to consider acute disseminated encephalomyelitis. So vaccination is the more important thing over here to focus. Okay, so basically this is basically your demyelination after the patient was vaccinated. That's that. Okay, next one. Next one is a very odd, annoying, and extremely high yield disease. Okay, I find this really odd because the presentations are very odd by themselves. The name of the disease is very odd. Okay, and the reason why USMLE likes to make questions regarding this disease is very odd too. Okay, so all in all, it's a very odd disease. Okay, so what's the name of this odd disease? The odd disease name is Charcot-Marie-Tooth disease. Charcot-Marie-Tooth disease. Okay, and this is basically a hereditary motor and sensory neuropathy, meaning that it's hereditary, like previous generations of the family members also had the same disease. Okay, so what happens is there's defective productions of proteins, okay, which are involved in the structure and functions of the peripheral nerves. So this is basically a problem with protein production. So and if there is a problem with protein production, we know that there is a gene involved. Okay, there is a gene involved, and if there is a defect in the gene, then there will be a defect in the protein. And if there is a gene involved, then this disease is a familial disease, and it's just connecting the dots. Okay, that's what it is. So basically, it's an autosomal dominant, meaning that if the mother and father, both of them had it, then 50% of the chance their two of their child will have the disease. Okay, and that's that. And it is associated with foot deformities. Okay, foot deformity, low extremity weakness. Okay, and sensory deficit. So basically, what are you expecting in your patient with Charcot-Marie-Tooth disease? Charcot-Marie-Tooth disease are your patients who has demyelinating disorders along with pes cavus or hamartomas. Okay, what is a pes cavus? Okay, what is a pes cavus or hamartoma? Okay, so this is known as pes cavus. So if you see a patient with this type of feet, meaning a hammer toe, along with that, the patients also have demyelinating disorder. For example, the spinal cord demyelination, such as weakness, spasticity, cerebellar demyelination syndromes.
Okay, and along with that, if they have hamartosis, um, and lower extremity weakness, meaning foot drop, these patients are your patients of Charcot-Marie-Tooth disease. And USMLE will try to make this question very easy for you by mentioning pes cavus or hamarto and putting a lot of emphasis on the fact that your patient has pes cavus. If you see a question where they keep on telling you that you have a patient who has pes cavus, and along with that the patient has weakness, always remember pes cavus, pes cavus, pes cavus plus weakness of limbs is Charcot-Marie-Tooth disease. Okay. Pes cavus plus weakness is Charcot-Marie-Tooth disease. Nothing else. There's absolutely nothing else you have to remember from over here. We'll write this down over here so that you do not get overwhelmed by this disease. It's very easy. Charcot-Marie-Tooth disease is pes cavus plus weakness. That's it. Pes cavus and weakness. Okay. And now, if they want to make the question a bit more difficult, they can ask whether you have the knowledge of the fact that the gene deletion is by PMP22. Okay, PMP22. That's what it is. PMP22. I wish there was a better way for me to make you guys remember PMP22, but unfortunately, there's not. Okay, PMP22. It does not go with any mnemonic. Okay, this is just something which you have to swallow. That's what it is. PMP22. This is the gene. Okay, with Charcot-Marie-Tooth disease. Okay, so what I would do is, okay, let's look at a child with Charcot-Marie-Tooth disease. Let's see how they present it.
The spinal cord and the extremities, the arms and legs, don't work properly, and there are various different reasons for that, depending on the type. But the ultimate result is that the muscles weaken, mainly in hands and feet, but it can get worse over time.
1 second, please. Let me see if I can find a proper.
Charcot-Marie-Tooth disease, or CMT, but there is new treatment that may halt C.
I did have difficulty walking, but I had the mentality of I'm just going to do whatever I can until I physically can't do it anymore.
Dakota was diagnosed with Charcot-Tooth disease.
Okay, look at the feet of the patient. Okay, look at the feet of the patient. Do you see the pes cavus and the hammer toes? Okay.
A condition that often leads to weakened muscles on the bottom of the feet.
When they're walking, their foot is hanging down and they're unable to lift it.
As Dakota's condition worsened, 4 surgeries over 8 months allowed her to walk without braces and start college at the New York Fashion Institute of Technology.
So proud of her.
Okay. Do you guys have some idea about the Charcot-Marie-Tooth disease then? Okay. Okay, good. Once again, I apologize for showing you the videos, but if you see the videos, then you can easily remember the cause, okay? So this will take some time, but seeing the videos once will help you remember Charcot-Marie-Tooth disease for a long period of time. So this is our friend over here, okay? Unfortunately, our friend got diagnosed with Charcot-Marie-Tooth disease, okay? And as you can see that in her feet are pes cavus, I mean hammer toes, and at the same time, there's weakness in her feet. And the weakness is so brutal, and the bones are so brutal that they had to have around 8 surgeries done, after which she had some possibility of walking. Okay, so that's that. So that is basically the Charcot-Marie-Tooth disease, in which there is demyelination of the nerves along with weakness of the muscle and pes cavus or hammer toes. That's what it is. Okay, so that is your Charcot-Marie-Tooth disease. Okay, so hopefully after seeing the video, you guys will not forget Charcot-Marie-Tooth disease, and that's my goal. Okay, so that's the goal. And once again, the gene is PMP22. Okay, the gene is PMP22. Okay, next one. Next one is progressive multifocal leukoencephalopathy. Progressive multifocal leukoencephalopathy. Okay, and what this is this is basically a demyelination of CNS. This is basically a demyelination of CNS, and what happens is the demyelination of CNS is due to destruction of oligodendrocyte, and we know that. Okay, But the reason for this progressive multifocal leukoencephalopathy is by reactivation of a virus such as JC virus. Who knows the name of JC virus? The full main name of JC virus. Let's see who knows the name. Okay, if anyone is thinking about Girovici, it's wrong. Okay, do not think about Girovici. What is the name of JC virus? The full name for JC virus. What is the full name? What does JC stand for? Anyone? Nope. Jacob Crookfield. Nope. John. Okay, we have one doctor who said John Cunningham. There you go. The name of the virus is John Cunningham virus. Okay, the name of the virus is John Cunningham virus. John Cunningham was the scientist who died, who named the virus as JC virus, because this is the virus which stays latent in your brain. And what happens is that that in patients who are immunocompetent, who have a proper, good, absolutely beautiful immune system, they will have no problem with the virus. Okay, but patients who have destructive or weak immune system, that is an AIDS patient, they have this disease in which the virus gets activated, and this virus causes demyelination of the oligodendrocyte. Once again, demyelination is shown by white. Okay, keep in mind, every time you see white over here, either if it's not hemorrhage, then it's demyelination. Okay, and predominantly it involves the parietal and occipital cortex. Okay, and once again, what is the name of our friend who has PML? There we go. Okay, Natalie. Okay, our poor friend Natalie. Not only does she have MS, Natalie has MS. She also has PML. Okay, progressive multifocal leukoencephalopathy. Okay, so with that mnemonic, okay, write that down. With that mnemonic, you can also see that we are using natalizumab to treat PML. Okay, natalizumab to treat PML. Are we clear? Are we clear? Okay, our poor friend Natalie got diagnosed with so many diseases, multiple sclerosis. Now she has AIDS. Okay, for which she has PML. Okay, so that's that. Okay, so are we done with are we done understanding the demyelinating disorder? If yes, then we are going to do a revision. Anyone? Not that common. Epidemiologically, Charcot-Marie-Tooth disease is not that common. You do not see Charcot-Marie-Tooth disease every day in your hospital. Okay. Okay, so let's start. First of all, you have a patient who has come to you with urinary incontinence. The patient has a weakness and spasticity of the lower limb, and it's a young female who's 20 to 30 years old. The patient has unilateral vision loss. Okay, MS. Okay, by that, you guys, okay, MS meaning multiple sclerosis. And what we find in the CSF of multiple sclerosis is fast answers. What do we find in the CSF of multiple sclerosis? Oligoclonal bands. Next one is, you have a patient who has come to you with hyponatremia, but you were so busy that you have infused fast infusion of hypertonic solution of normal saline. Now this patient has a syndrome in which he is locked in. What is the name of the syndrome? Central pontine myelinolysis. Okay, now you have a patient who has ascending symmetric paralysis of the lower limbs, and the patient had a past infection of diarrhea. Okay, what is the name of this condition? GBS. Okay, next one is, you have a young child who was vaccinated recently. After vaccination, the child has weakness and spasticity. Okay, and what is the name of this condition? Fast answers, please. What is the name of this condition? Okay, post-infectious encephalomyelitis. Okay, next one is, you have a patient who has come to you with hammer toes, weakness of the limbs, weakness and spasticity. Patient cannot walk. What is the name of this condition? CMT. What is the gene that is associated with CMT? What is the gene that is associated with CMT? PMP22. Okay, next one, you have a patient who has come to you with wild flinging of the arms. His father also had the same problem, but he has developed that issue at the age of 30 years old. What is the name of that condition? Fast answers, please. While fringing of the arm. Okay. Then you have a patient who has come to you with with a gradual onset of dementia. Okay, gradual onset of dementia, and the patient also has an ApoE4 positive Alzheimer's disease. Next one is you have a patient who has come to you with tremor, rigidity, and then akinesia, bradykinesia. Okay, shuffling gait. Okay, Parkinsonism. Okay, and as you have a patient who come to you with episodes of memory loss and a past history of stroke, stroke or ischemia or atherosclerosis. Patient has hypertension. Okay, next one is you have a patient who has come to you with with startle myoclonus. Okay, the patient has come to you with startle myoclonus. Okay, what is the name of the condition in which the patient gets startled? So go. What is the name of the condition? The patient has dementia along with hallucination. Dementia along with hallucination. Lewy body dementia. What is the name of the condition in which there is personality changes? After that, the patient has dementia, personality changes, and then the patient has dementia. Pick's disease. Okay, I'm clapping for you guys right now over here. Okay, so clap. Okay, good job. Okay, you guys have successfully. Okay, you have a question. What is your question, please? What is your question, Dr. Jordan? Right. Okay. So what? So the thing is, okay. So the thing with natalizumab is, what is natalizumab? What is natalizumab? What is natalizumab? Does anyone have any idea what natalizumab is? Okay, so it's a monoclonal antibody. Basically, that's what it is. So natalizumab is a monoclonal antibody. So what happens with natalizumab is if you treat a patient with natalizumab in case of progressive multifocal leukoencephalopathy, okay, so for the initial treatment, so in questions in MBOS, okay, in questions in MBOS, they have options for treatments of PML with natalizumab. And in initial treatments with natalizumab, if the treatment is well controlled and slow, then there is absolutely no risk while with the association of progressive multifocal encephalopathy. But if you have increased infusions of natalizumab, okay, so IV infusions of natalizumab without proper supervision, okay, without proper supervision, what happens is with progressive multifocal leukoencephalopathy, the antibody goes and it further causes demyelination. So the thing is, this demyelination results in more activation of the JC virus. Okay, this results in more activation of the JC virus, and this results in increased risk of having more progressive multifocal leukoencephalopathy with natalizumab. So the thing is, even though natalizumab is to some extent used to treat PML, but the risks are more. I mean, there's increased risk of having PML with natalizumab. So the reason why I said that it is used for treatment of PML, it's because you will receive some questions in MBOS in which they expect the answers to be natalizumab. Okay, so you can keep that in mind. Having said that, treatments for natalizumab and increased risk for PML with natalizumab is not that very high yield for which you will be asked a lot of questions. Okay, but if you are, just try to understand what the question is asking you. If they're asking you about the increased risk or which drugs to avoid, then natalizumab could also be your answer. But if they're also asking you that which drugs are used to treat PML in a slow, sustained fashion, under supervision, then natalizumab is also your answer. Are we clear? Are we clear? Okay, who asked the question? Okay, to Dr. Jordan. Are we clear now, Dr. Jordan? Okay, you got it now. Okay, good. So that's that. Okay, so we have finished demyelinating disorders, and now we will move on to a very important and a very difficult topic over here. That is neurocutaneous disorders. Okay, that is neurocutaneous disorders. Okay, so first of all, before we begin our discussion on neurocutaneous disorders, have you guys seen my video on neurocutaneous disorders already in my page? Very good. Azam has seen it. Okay, you have not seen it. Who else have seen it? Okay. Okay. So this is what I propose to you guys. Okay. So this is what I propose to you guys. First of all, what since I have already made a video about neurocutaneous disorders, what I'm doing right now is I will not skip through this. Okay, I will not skip through this. But what I would want you guys to do is if you can look at that video. Okay, if you can look at that video which I made about neurocutaneous disorders, and after looking at that video, we can speed up the whole process of discussing this tomorrow in our revision and recapitulation section, and we can discuss the whole things again. Because what would happen if we try to study neurocutaneous disorders right now, this will take a lot of time because there are a lot of things that we have to master right now. Okay, so that's why I made the videos on an earlier basis for you guys and also for everyone else, for all the students, for all the people who are not my students, and for everyone who are my students, so that we can speed up the process. Because I knew that when we will study neurocutaneous disorders will be a hard topic to master right at this moment. So is that something you guys would be interested in, or do you guys want to read it right now and finish it right now? Or do you guys want to do the thing which I proposed, that is, watch the video which I have made on neurocutaneous disorders? Okay, so and for everyone, I also watch it on neurocutaneous. Okay. Okay, 1 second. I don't even know what's going on again. Okay, so the thing which I wanted to show you was that the video is available on YouTube. Okay, so if you write neurocutaneous disorders and you write Dr. Heidery by its past, then you can see that that video is it's already present in your it's already there in YouTube. So do you guys want to do that, or do you guys want to read it? Okay. Okay, good. So if you guys want, we can discuss. We can watch the video. You guys can watch the video at home, and we can discuss it tomorrow. I think this will speed up the process. Okay. So only if everyone agrees, then can I move on. If anyone disagrees, then I will try to read it right now. Anyone disagree with the person? Okay. Okay, you guys agree. Okay, good. So that's what it is. Okay. So that's that. Okay, now the next one that we will come to is adult brain tumors. And with adult brain tumors, I also have videos, but I will not ask you guys to go back home and read and watch my video on adult brain tumors. I will discuss adult brain tumors right now. Okay, I will discuss adult brain tumors right now. Okay, so you have nothing to be worried about. So that's what we will do. So before we start with the adult brain tumors, do you guys want to take a short break, or do you guys want to read it right now? Okay. Okay. Let me just see very quick how many topics we have so that we finish pathology. Do we have the adult brain tumors? Okay. 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 All right, no problem. Neurology itself is around 100 pages, so 80 to 90 to 100 pages, so that's why. Okay, so what we can do is we can take a short break and then we can be back. Okay, so let's take a break. Let's come back in 10 minutes and then we can finish neurology today. Okay. Okay, is everyone back from their break? Is everyone back? Okay, okay. So, okay, what we would be doing is we would be discussing about the adult brain tumors. Okay, so even after we're done discussing the yes, of course, we will send you the UL notes, no problem. So even after we are done discussing the adult brain tumors, I really want you guys to go and see the videos on the adult brain tumors, because that video on adult brain tumors, which we have made, is will be more detailed, okay, because I took a lot of time in discussing the adult brain tumors because it's very high yield, and I will also try to do the same right now. But since there is a video over there, and along with the Neurocutaneous disorder video, please try to go and see that video too, to see if you have any confusion, you can clear your confusion from over there. Okay, okay. So what we would be doing is we would be, okay, we will be talking about the adult brain tumors. The adult brain tumors are glioblastoma, oligodendroglioma, then we have meningioma, okay, then we have hemangioblastoma, okay, then we have pituitary adenoma, and then we have schwannoma, okay, then we have schwannoma. So basically these are the adult brain tumors. And whenever you talk, whenever you come across a questions about a brain tumor in an adult, this is the initials which you have to remember. So basically, there are other tumors such as pilocytic astrocytoma. Then we have ependymoma. Okay, those things are pediatric brain tumors, so they will never be associated with an adult brain tumor, and that is what you have to realize. Okay, so they will never be associated with an adult brain tumor. So if you can remember this mnemonic, if you can remember this initials, okay, we will come up with a mnemonic for this very soon. If you can remember this initial, then we can then you can remember all the adult brain tumors. So basically, if they are talking about an adult who has a brain tumor, this could either be glioblastoma, this could either be oligodendroglioma, either a meningioma, hemangioblastoma, pituitary adenoma, or a schwannoma. Very rarely will a pediatric brain tumor be present in an adult. Okay, so with that being said, we will come up with a mnemonic for this very soon. Okay, has anyone watched the video on my adult brain tumors? Anyone? You can type in Dr. Haileri. Has anyone seen my video on adult tumors? Okay, Dr. Hossam, you watched. What was the mnemonic I used for the adult brain tumors? Since you watched the video, what was the mnemonic that I used for adult brain tumors? Do you remember? Anyone? Okay, you do not remember. Okay, so no problem. So we will tell you that a mnemonic after the end, after we have discussed all the tumors. Okay, so first of all, the first tumor that we will talk about is glioblastoma multiforme. And this is one of the most common tumor. Okay, G4, glioblastoma multiforme. The first tumor is glioblastoma multiforme. And basically, the good news is the questions will come from these sides, from the description, and the answers will either be over here, or the answers will either be over here. Okay, meaning that they will describe you the tumor in the question stem, and they will either ask you for the diagnosis. If they ask you for the diagnosis, the name is enough. If they ask you for the histology, then you have to make the diagnosis in your mind at first and then answer with the histology. That's it. So what is a glioblastoma multiforme? This is basically a grade 4 astrocytoma. So we have astrocytes in the brain. So what are the astrocytes used for? Astrocytes, what is the function of the astrocytes? Okay, good. So basically repair and Even the food process of astrocytes are used for blood-brain barriers, okay, and nutrition to some extent. So that's it. So if you have malignancy of the astrocyte, and that malignancy is known as glioblastoma, and this is one of the most commonly malignant brain tumor, okay, and basically the survival rate is very small, that is 1 year, okay. And the thing with the glioblastoma is that there is a butterfly lesion, okay. There is a butterfly lesion, meaning that if this is the corpus callosum, okay, the lesion over here, okay, the lesion over here is like a butterfly, meaning that the tumor can cross the, okay, so this is the butterfly, okay, this is the butterfly lesion. So the tumor over here can cross the corpus callosum, and this is the butterfly lesion. So this is also known as a butterfly glioma. Okay, and what we what we have what's very important for glioblastoma is this histological appearance. That is, there is a central necrosis. Okay, so as you can see that there's a central necrosis over here. So this is the area of central necrosis. Okay, and it is bordered by palisading or pseudo palisading. So what do you mean by pseudo palisading? Pseudo palisading meaning that the cells are emerging or tall, but it looks like they are emerging or tall, but they are not. So that is pseudo. Okay, so pseudo palisading histiocytes or pseudo palisading tumor cells. Okay, so there's a central necrosis surrounded by a which is surrounded by a pseudo palisading tumor cells. Okay, so this is basically your glioblastoma. And another thing is the glioblastomas are GFAP positive. So glioblastomas are GFAP positive, meaning that they are glial fibrillary acidic protein positive. So that's what it is. And these are all the information that you have to remember about glioblastoma multiforme. Very easy to remember. First of all, they are the most common tumor. They are the tumors of astrocytes. They can cross the blood. They can cross the corpus callosum, form a butterfly lesion, and in the histology, they have a central necrosis surrounded by pseudo-palisading tumor cells. That's that. Okay, are we clear? Are we clear about glioblastoma? Okay. Okay. Next one. Next one is about our friend. Okay. The name of our friend is Ollie. Okay. Okay. The name of our friend is Ollie. Okay, so we have a friend. His name is Ollie, and Ollie, there's something about him is that every time when he wakes up in the morning, okay, our friend Ollie, who is an adult, okay, Ollie is an adult who wakes up in the morning, and every morning he tries to have fried eggs with chicken. Okay, Ollie loves to have fried eggs and chicken in the morning. Okay, so what happens with this one is Ollie and his liking for fried egg and chicken in the morning is our mnemonic for oligodendroglioma. Oligodendroglioma, meaning that these are the tumors of oligodendrocytes. And what are the oligodendrocytes? Before you guys tell me, I'm going to tell you myself that basically oligodendrocytes are the cells that are used for myelinating the nervous system or the white matter of the central nervous system. That's what it is. Okay, so these are relatively rare, meaning that they are rare, and they are most often in the frontal lobes. Okay, so these are basically frontal lobar lesions. Okay, so these are basically frontal lobar lesions. These are not butterfly lesions. These are frontal lobar lesions. And these lesions, what they do is when you can do a histology, what you can see is you can see that they have cells which have a fried egg appearance. That's sunny side up. Okay, that's what Ollie likes to have, sunny side up egg. The egg, meaning that the white part of the egg and the central yolk. Okay, this is the fried egg appearance. And along with that, Ollie also likes to have chicken in the morning. So they also have chicken wire. Okay, and what is a chicken wire? Chicken wires are basically these wires which are used to guard off chickens in the backyard, or they are used to guard off chickens in the chicken farm. Okay, so this is basically how a chicken wire would look like. Okay, the chicken wire appearance. So that's what it is. Okay, so these are the type of wires which you see in farms. Okay, and this type of chicken wiring is seen over here. As you can see that these wires over here, they have the chicken wire appearance. So our mnemonic for Ollie, who likes to have fried egg and chicken in the morning, is our story for oligodendroglioma, which are lesions that most commonly occur in the frontal lobe. They have a fried egg appearance, and they also have chicken wire appearance. That's what it is. Okay, are we clear about oligodendroglioma? Yes, are we clear Okay, so far we studied only two. Okay, so far we studied only two. Okay, next one is a meningioma. Okay, next one is meningioma, and meningioma. Okay, meningioma, men. Okay, meningioma is not common in men. Okay, what is this mnemonic? So meningioma is that type of a tumor which is not common in men, and they are more common in females. So what happens is these tumors, they are basically extra axial, meaning that they're outside of the axiom of the brain parenchyma. And the most easiest way you can diagnose a meningioma, and this is very easy and fun to diagnose, it's because they have this thing known as a tail. Okay, they have a tailed appearance. Okay, so they have a tail appearance. And what and so then the thing is, they will remain asymptomatic, and if they want to cause the symptoms are usually the same symptoms of tumor, that is pressure signs and seizures or focal signs, meaning that if the tumor presses on any structures over here, that they will cause focal neurological deficits. Okay, and what is the treatment? The treatment is basically resection and radiosurgery. So that is very easy. So basically you have to resect the tumor followed by radiation. That's what it is. Okay, and what happens over here is that these tumors, if you do a histological appearance, okay, if you do a histological appearance, they have this whorled pattern. Okay, they have this whorled pattern. Okay, what is the name of another tumor in females that have a whorled pattern? What is the name of another tumor in females that have whorled pattern appearance, and it's a common benign tumor? Okay, what is the name of that tumor once again? Okay, we have ovarian cyst adenoma does not have a whorl muscular pattern appearance. The answer is leiomyoma or fibroid. Okay, so fibroids are tumors of the uterus in which you have whorled appearance. And if you can remember the whorled appearance of fibroid in tumors, or the whorled appearance of fibroids, and fibroids, they usually occur in females, then meningioma is the same, more or less, that the histology has the whorled appearance, and they also occur in females. So basically two tumors with whorled appearance, and both of them are occurring in females. First of all, it's a fibroid. Fibroid is occurring in the uterus, and for obvious reasons, females have a uterus, and that's why the fibroids are there. Okay, but over here, meningioma is also another type of tumor, which are also occurring in females, because in females, the meningiomas are more common, and just like fibroid, the meningiomas have whorled appearance. That's what it is. They have whorled appearance, and the cells are basically spindle cells. Okay, so what are spindle cells? Spindle cells are the sharp cells like this, like these sharp appearing cells. Okay, the sharp appearing cells, and these are known as spindle cells. And these spindle cells are okay. This is how they are arranged in a whorled pattern. Okay. Okay. So this is the whorled appearance of the meningioma, this whole whorled appearance. Okay, so this is the spindle cells appearance of the meningioma. That's what it is. And they can also get calcified, and if they get calcified, this is known as a psammoma body. So basically, they can also get psammoma body. So before we move on to hemangioblastoma, we have talked about three tumors: glioblastoma, which is a grade 4 astrocytoma, which can form butterfly lesions across the corpus callosum. On histology, they have a central necrosis surrounded by pleomorphic tumor cells. Done. Number 2 is oligodendrocyte, for our friend Ollie, who likes to have fried eggs and chicken in the morning. So fried egg appearance and chicken wire, and they occur in the frontal lobes. Next one is meningioma, which are not common in men. They're more common in females, and in females there is another tumor that is fibroids. Fibroids have whorled pattern. Meningiomas also have whorled pattern, and the whorled patterns are formed by spindle cells. Are we clear on these three tumors? Are we clear on these three tumors? Okay. Okay. Does this make studying the tumors easier or difficult? Easy to study or difficult to study? Very easy. If you can incorporate the story behind the tumor, then it's absolutely easy. Okay. Okay. Please let me know if it's difficult. I will repeat it again. Next one is hemangioblastoma. Okay, next one is hemangioblastoma. Hemangioblastoma is associated with a neurocutaneous disorder known as von Hippel-Lindau syndrome. Von Hippel-Lindau syndrome is known as HARP disease. HARP for hemangioblastoma, angiomatosis, bilateral renal cell carcinomas, and pheochromocytoma. So you guys will read this when you guys when you guys stay at home after the lecture, and you guys can see the video and you guys can read von Hippel-Lindau. So and anyone who has von Hippel-Lindau disease can also get hemangioblastomas. And basically hemangioblastomas are basically tumors of blood vessel origin. Okay, so they arise from the blood vessels. And the problem with these tumors are that these tumors, they are basically present more in the cerebellar or in the brainstem region. Okay, and the thing is with hemangioblastomas, what they have is they have thin wired capillaries. Okay, closely arranged thin wired capillaries, and this makes sense. I'm going to tell you why. Is let's say that this is a blood vessel. Okay, and if you have a tumor arising from the blood vessel, will it push the periphery? Yes or no? Will it push the periphery of the blood vessel? Yes or no? Yes. If it's the periphery of the blood vessels, the walls of the blood vessels will get thin. Yes or no? Will get thin. Yes or no? If they push the periphery blood vessels, the walls of the blood vessels will get thin, yes or no? Yes, and the answer is yes. So there will be thinning of the walls of the blood vessels, especially the capillaries. And if they are pushing the walls of the blood vessels, and there are a lot of blood vessels over here, okay, and there are a lot of blood vessels over here, the intervening parenchyma, that is the space between the blood vessels, will they increase or decrease? Will they increase or decrease if they push the blood vessels? Decrease, that is correct. The decrease, that is correct. So that's exactly what they said. They said that it's a blood vessel origin. They are very closely arranged, thin-walled capillaries with minimal intervening parenchyma. So the amount of parenchyma that is inside is this is very less, or this has decreased. And the tumor, as you can see, is present here on the cerebellum. Okay, so that's what it is. So that is about the first 4 tumors of the adult. Okay, so fast. Okay, so first of all, okay, wait for a minute. What I will do is, instead of asking you the questions, let me finish these 2 and then I will ask you the questions. Okay, 1 second. Okay, next one. Next one is very easy to understand because next one is pituitary adenoma. Okay, and before I discuss pituitary adenoma, you guys will tell me about pituitary adenoma before I discuss pituitary adenoma. First of all, what is the most common location of pituitary adenoma? Fast answers, please. What is the most common location of pituitary adenoma? Optic chiasma. Okay. Have you guys heard of the location called sella turcica? Sella turcica. Okay. Okay. What is sella turcica? Right, pituitary gland sits there. Okay, so if there is a tumor of the pituitary gland, which part of the optic nerve stem will be put pressure on? Which part of the optic nerve stem will there be pressure on? Optic chiasma. If you have pressure of the optic chiasma, what is the visual field defect that you will expect in your patient? Bitemporal hemianopia. Very good. So you get bitemporal hemianopia. Okay. Okay. Next one is what is the medical treatment that we can use to decrease the okay, so the most common pituitary adenoma. What is the most common pituitary adenoma out of all the adenomas? Could it be from a lactotroph, somatotroph? Which one? Prolactinoma. Very good. The most common pituitary adenoma is a prolactinoma. So there's increased amount of prolactin being secreted. Do you remember our synonym dopamine? Dopamine. Dopamine. Yes. Okay. So the function of dopamine, will it increase prolactin or decrease prolactin? Decrease prolactin. They will decrease prolactin. So what's the treatment of pituitary adenoma if it's a prolactinoma? Should we give dopamine agonists or antagonists? Dopamine agonists. What are the name of some dopamine agonists? What are the names of some dopamine agonists? Bromocriptine and cabergoline. Bromocriptine and cabergoline. Okay. Okay. Okay, let's see if you guys have said everything that you need to say in the description. So first of all, you guys have said that the most common location is in the sella turcica, which causes bitemporal hemianopia due to pressure in the optic chiasm. What we failed to mention was pituitary apoplexy. We mentioned this in the endocrine, that pituitary apoplexy is basically a damage or destruction of the pituitary gland, either by hyper or hypo due to the absence of blood supply or necrosis. Okay, and the most common cause of pituitary adenoma is a prolactinoma, which can cause galactorrhea, amenorrhea, decreased bone density, and decreased libido. And we know that dopamine, also known as dopamine, this is for all the previous students, which we have discussed. For all the new students, we use a mnemonic called dopamine for dopamine because dopamine decreases prolactin. Okay, so that's what it is. And another one is, so if it decreases prolactin, so dopamine is used for the treatment of prolactinoma, and the dopamine agonists are bromocriptine and cabergoline. So how amazing that you guys have said the whole thing even before looking at the description. Okay, so this shows that you guys are paying a lot of attention, and I thank you for that. Okay, and the surgery that we can use to resect a pituitary adenoma is known as a transsphenoidal resection. So we have the sphenoid bone, okay, the sphenoid bone of the face. They usually stay through over here. It's a very complicated bone, and then the sphenoid bone, we make a small hole in the sphenoid bone, and we approach the pituitary through the sphenoid bone, because this is how we can easily approach the sella turcica. And by the help of instruments, what we can do is we can take and resect the tumor, and then we can pull it out through the sphenoid. Okay, so there's no need to do an open skull surgery. There is no need to do an open skull surgery. Okay, and it will make things very complicated. All we can do is do a transsphenoidal approach. That's what it is. Okay, another thing is, what will you see if you do, or if you cut open the pituitary adenoma? If you cut open the pituitary adenoma, what will you see in the histology? In the histology, what you will see is there's hyperplasia of the endocrine glands. Okay, and along with this, you will see that the most common form is lactotroph, meaning that there is a prolactinoma. Okay, there is a prolactinoma. So basically, this is the type of lesion, and the pituitary adenoma is basically over here. So you see that this is the sella turcica, and the adenoma is over here. Okay. Next one is if it's a somatotroph, meaning that has instead of a prolactinoma, it's an adenoma of the somatotroph. Then obviously somatotrophs are involved with growth hormones, so the patients will get acromegaly in adults, gigantism in young children. Okay, then corticotrophs can result in Cushing disease, thyrotrophs can result in hyperthyroidism. Are we clear on pituitary adenoma? Okay. 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 Okay, next one. Next one is schwannoma. Okay, next one is schwannoma. Okay, so schwannoma is basically a very easy tumor to diagnose too. Why? Because the classical location of the schwannoma is at the cerebellopontine angle. Okay, so you have these cerebellum, and then you have the pons over here, and the schwannomas are basically on this side. Okay, and this side. Okay, and this is the common location through which cranial nerve 7 and cranial nerve 8 they go out. Okay, specifically 7 and 8. So what they do is they cause damage to the 7 and 8 one. Okay, and this can result in lesions of the facial nerve, or they can either result in lesions of the vestibulocochlear nerve. Okay, the patients can have hearing loss, and the patients can also get tinnitus. Okay, but the easiest way you can diagnose schwannoma is by looking at the location. Make sure if you see the tumor is over here. Okay, what is the name of this tumor? If it's over here, fast answers, please. We have just discussed this. What is the name of the tumor if the tumor over here instead of here? Hemangioblastoma. Very good, guys. Hemangioblastoma. And if the tumor is over here, then the tumor is a vestibular schwannoma. Okay, then the tumor is a vestibular schwannoma. And it's a Schwann cell origin, meaning that Schwann cells are the cells that are used to myelinate the peripheral nerves. Okay, and they're S100 positive. And which cells are S100 positive? We talked about this before. From which origin? So where are the cells coming from embryologically? Embryologically, where are the cells coming from? Which part of the embryo? Okay, there we go. So all the tumors which arise from the neural cells are S100 positive, and they are biphasic dense. So these are dense tumor, and they have spindle cells. Okay, so these are spindle cells which are organized in hypocellular. So these are hypocellular areas, meaning that there's less cell, and myxoid areas. Okay, so spindle cells in hypocellular, meaning that there is a small amount of cell, and myxoid stroma. Myxoid meaning myxomatous, all the connective tissue or the connective tissue substances over here, the myxoid stroma. Okay, the myxoid stroma. Can you guys tell me the name of another cardiovascular tumor which has a myxoid stroma? Cardiovascular tumor which has a myxoid stroma? Myxoma. That is very good. What is the most common location of the myxoma? What is the most common location? Left atrium. That is left atrium. And this is also another type of myxoid stromatous tumor, which is schwannoma. Okay. 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 Next one. Next one is we talked about the mnemonic. Okay, that we said we would come up with a mnemonic so that you can easily remember. Okay, we can easily remember the adult brain tumor. Okay, so whenever you get a question about an adult, okay, they will tell you the age. If they tell you the age is above 18, obviously it's an adult. Okay, so if they tell you that you have a tumor in an adult, first and foremost you have to think about these tumors: glioblastoma, oligodendroglioma, pituitary adenoma, meningioma, hemangioblastoma, schwannoma. And the mnemonic that we have used for this is get out, please, my head hurts. My head hurts. Okay, so get out, please, my head hurts. Okay, get out, please, my head hurts. So with all of this, you can remember easily the tumors that are used, that are common in adults. Okay, so can I give you guys 1 minute, after which I will ask you guys questions about this? Okay, please, I will ask you guys questions. Just try to remember all the things I have told you, and you can easily remember. The thing is, I will only ask one physician, I will only ask one doctor, because I want to see how each and every one of you can do if you are asked about all the lesions. Okay, so hope it will be really easy for you if you can just have one small read about what we just discussed, and I'm pretty sure you guys can answer it confidently. So I will give you guys exactly 1 minute. Read the adult brain tumors once again, because whatever reading and understanding, reviewing and recapitulation you have to do it right away during our lecture, because once again, the rest of your day should be focused on doing UWorld questions. Okay, so 1 minute on the clock. It's 11:24 as of right now. By 11:25, I want one physician, one brave physician, to say done so that we can ask the questions. Okay, let's go. Okay, still waiting on someone. Okay, please let me know. Anyone? Dr. Hussam? Okay, let's see if anyone is done. Okay. Okay, all right. So we have three physicians over here. Okay, Dr. Maheshwari, Dr. Hussam, and Dr. Hussain. Okay, so let's start with our friend Dr. Hussam. First of all, would you be kind enough to unmute yourself, please?
Yes, doctor.
Okay, what is the name of this tumor in which there is a butterfly lesion?
Glioblastoma.
Okay, what is the name of this tumor in which you have a frontal lobe lesion over here?
Oligodendroglioma.
Okay, what is the name of this lesion over here, which has an axial growth with a tail?
Meningioma.
Very good. Okay, what is the name of this lesion where you have, okay, what is the name of this lesion where you have a tumor over here in the sella turcica?
Pituitary adenoma.
Okay, good. What is the name of this lesion where you have a tumor over here at the cerebellopontine angle?
Schwannoma.
Very good, Dr. Hussam. Thank you so much for participating. Can we have the next physician, Dr. Hussain?
Yeah.
Yes, thank you so much for participating. And our question is, would you be kind enough to tell us what is the histological appearance of oligodendroglioma?
Fried egg and chicken wire.
Very good. What is the histological appearance of meningioma?
Meningioma. Spindle cell.
Okay, wait one second. Is meningioma more common in men or
female? Yeah, female and word appearance.
Very good.
Appearance. Yeah, sorry.
How did you make that association so quick?
Fibroma or ileum.
Okay, so in females there is another tumor that is common.
Leiomyomas, yeah.
And leiomyomas. And that's how you word. That.
Yeah.
Good.
Okay.
Next one. Next one is you have a patient who has been diagnosed with von Hippel-Lindau disease.
Yeah.
Okay. And the tumor is over here. What is the name of this tumor?
Hemangioblastoma.
It's not glioblastoma. Glioblastoma has a butterfly lesion.
Hemangioblastoma. Hemangioblastoma. Yeah,
Very
sorry.
good. It's hemangioblastoma.
Blastoma, yeah.
And hemangioblastoma, is it a blood vessel tumor?
Yeah. Blood vessel origin. Yeah.
Right. If it's a blood vessel tumor, then is it pushing on the blood vessels? Yes or no?
Yeah.
Okay. If it's pushing on the blood vessels, will there be thin wall or thick wall?
Thin wall.
Okay. And what about the intervening tissues? Will there be more tissue or less tissue? Intervening parenchyma. Will there be more or less?
Less also. Sorry.
That is good. Less.
Yeah.
There's no need to apologize. You said the exact same thing. Look, it says blood vessel, thin wall, minimal intervening parenchyma. That's what you said. So that's
okay. Yeah.
Okay, very good.
Minimal intervening.
Okay, very good. Thank you so much, Dr. Singh. Can we get
okay, thank you for you. Thank you.
You are welcome. Can we get Dr. Maheshwari on the mic? No, Dr. Maheshwari.
Yes, here.
Okay, so what is what are the sign symptoms of pituitary adenoma? Sign symptoms of pituitary adenoma.
Acromegaly, gigantism, and
Sorry?
The non-functioning signs symptoms of pituitary adenoma on the sella turcica, which puts pressure on the optic chiasm.
Bitemporal hemianopia.
Very good. Bitemporal hemianopia. Okay. And another one is if you have a patient with a tumor at the cerebellopontine angle, what are the nerves that will get affected?
Cranial 5 and 8.
Okay, very good. If you have 5 and 8 or 7 and 8?
5, 7, and 8.
Oh, mostly 7 and 8, 5 to some extent, not a lot. Okay, the most important ones are 7 and 8. Okay, good. And the next one is glioblastoma multiforme. Can you please tell us what is the histological appearance of glioblastoma multiforme?
There is central necrosis surrounded by microvascular proliferation.
Very good. Thank you so much. That's exactly what we were expecting to hear, and that's what you said. Okay. Are we clear from everyone else who has heard our discussion on the active participation? Okay. Okay. Did you realize how it was for Dr. Hussein, Dr. Maheshwari, Dr. Hossam to make the associations, because only they could remember the stories associated behind it. Okay. Next one is, please tell me the mnemonic for the adult brain tumors. What is the mnemonic for adult brain tumors? The mnemonic for adult brains. Get out, please, my head hurts. Get out, please, my head hurts. Get out for glioblastoma, oligodendroglioma, and we have pituitary adenoma. Okay, get out, please. You have to say please. Get out, please. If you don't say please, you will miss out on pituitary adenoma. Okay, and M for meningioma, H for hemangioblastoma, S for schwannoma. Okay, okay. So we get a lot of, we see a lot of posts on USMLE Step 1 preparation group, and we see a lot of students struggling with adult brain tumors. Okay, so if you, are you guys okay with understanding the adult primary brain tumors? Do you guys realize how easy it is right now for you to diagnose the adult primary tumors? Okay, so next, if you guys see anyone struggling with the adult primary brain tumors, okay, will you be confident to make them understand the adult primary brain tumors in less than few words? Okay, okay, good. That is very good. Okay, always remember that our knowledge is not only our knowledge. Okay, everyone deserves to know the easiest way to learn something. Okay, so if you need, please let anyone else know who is struggling with adult primary brain tumors, how they can study adult primary brain tumors like you have studied. Okay, so please spread the knowledge so that it's easy for everyone to understand. Okay, good. Next one. Okay, next one, what we will study is P, M, E, C, and P. Okay, so what are we talking about? So just the same way we have discussed about the adult brain tumors, now we will do our discussions on childhood brain tumors or pediatric brain tumors. Okay, so pediatric brain tumors, that's what we will do. So what are the pediatric brain tumors? First of all, the first tumor that we will study about is pilocytic astrocytoma. Pilocytic astrocytoma. And we talked about the fact how a high-grade malignant astrocytoma is known as glioblastoma multiforme, and a low-grade astrocytoma, okay, low-grade astrocytoma is known as pilocytic astrocytoma, and this is the most common primary brain tumor in childhood. So if that's what we can say, then what is the most common cell in the brain that can undergo malignant transformation? Which is very good, astrocytes. And find this, and this is a question. Okay, this is a question from you world. Write it down in your book. Which is the what is the most common cell in the brain that can undergo malignant transformation? And this is a question from you world. Okay, and the answer is astrocyte. Okay, okay. So let's go. So it's a low-grade astrocytoma, most commonly primary brain tumor in childhood. Okay, and what happens is it's usually well circumcised, as you can see over here. It's found in the posterior fossa. So you have the anterior fossa over here in this region. Okay, and this is the posterior fossa, and the most common location for pilocyte, P for pilocyte and P for posterior fossa. So it's a posterior fossa tumor. Okay, and always remember that there's another way that you can diagnose the tumors in adults and in the child's in childhood. Do you guys know about tentorium cerebri or tentorium cerebri? Okay. Okay. Always remember all the tumors. Have you guys watched videos on pathoma regarding brain tumors? Have you guys watched videos on pathoma regarding brain tumors? Yes or no, please? Yes or no? Not okay, good. So the thing is, if you watch the videos on adult primary or pediatric primary brain tumors on pathoma by Dr. Hussein A. Sattar, what he would do is he will tell you that there are tumors which are occurring above the tentorium cerebri, and those tumors are childhood tumors. The tumors that are occurring below the tentorium cerebri are adult tumors in most cases. So most of the tumors of the childhood are supratentorial. Okay, they are above the tentorium, and the prognosis is a very good prognosis over here. Okay, so what we can see is over here in the histology, what we will see is we will see Rosenthal fibers. Rosenthal fibers. So Rosenthal fibers are basically fibers which have rose-like appearance. So these are small roses. Okay, so okay, Rosenthal fibers. So these are roses. Okay, as you can see, I just drew a rose over here. So Rosenthal fibers. And what are Rosenthal fibers? Rosenthal fibers are basically the name given for eosinophilic corkscrew fibers. So eosinophilic corkscrew fibers, if you do another microscopy of the fibers, you will see that it's a eosinophilic corkscrew appearance. That's what it is. And it could either be cystic or it could either be solid. Okay, that's that. Okay, keep in mind, do not worry, I will come up with a story in which every one of this will be very easy for you to recall and remember. Okay, so first of all, the first of all is a pilocytic astrocytoma. It's a pediatric brain tumor, occurs in the posterior fossa. Okay, and what happens over here? It's a Rosenthal fiber. Okay, so as you can see, if you can do a microscopy or a histology, you will see that there are Rosenthal fibers, which are eosinophilic corkscrew fibers over here. Okay, next one is medulloblastoma. Medulloblastoma is the most common malignant brain tumor in childhood. Okay, most common malignant brain tumor in childhood. And how you can remember, how the best way you can remember medulloblastoma being extremely malignant is if you what does the medulloblastoma do? Medulloblastoma destroys the brain, or medulloblastoma blasts. Okay, they blast the brain. Okay, so if you have a gun and you shoot the brain blasts and the brain the brain dies. Medulloblastoma is a excessively aggressive disease. So focus on the name blast. Okay, so most common malignant tumor. Okay, this involves the cerebellum. So that it involves the cerebellum. And the thing with medulloblastoma is the most common thing that they do is they cause a non-communicating or obstructive hydrocephalus. And if they have an obstructive hydrocephalus, what they do is they can cause the signs symptoms of headache, papilloedema. Okay, and that's what it is. Another thing which medulloblastoma is very notorious for is medulloblastoma. What they do is medulloblastoma, they cause a condition known as drop metastasis. What they do is they cause drop metastasis over here. So what is drop metastasis? Drop metastasis is basically, okay, so let's say this is the brain, okay, and this is the spinal cord. If you have the medulloblastoma over here, the parts of the tumor will break from this tumor, and this will fall in the spinal cord. Okay, this will fall in the spinal cord, and it will get deposited over here in the spinal cord, and from here the tumors will start growing, Okay, Okay, so primarily it's not a tumor of the spinal cord. It's a tumor of the brain, which has broken from the brain. Now it has dropped into the spinal cord, and now it's growing in the spinal cord. This is known as drop metastasis. And the tumor that is responsible for causing drop metastasis is medulloblastoma. Okay, so that's what it is. And and another thing is, if you do histology, okay, you can see that it's a neuroectodermal tumor with Homer-right rosettes. Okay, once again, these small blue cells, that you can see over here, these are actually small rose-like cells. Okay, small rose-like cells, which are known as Homer-right rosettes. So small blue cells are known as Homer-right rosettes. Once again, keep in mind, we will come up with a story to figure everything out. Just for now, just keep in mind that you have Homer-right rosettes for medulloblastoma and Rosenthal fibers for pilocytic astrocytoma. Okay. Okay, that's that. Nothing else. It's also synaptophysin positive, and tumors of the neuroectoderm are synaptophysin positive. And we talked about this when we talked about carcinoid syndrome or carcinoid tumor, which is also a neuroectodermal tumor. Okay. Okay, next one. Next one is an ependymoma. Ependymoma. Okay. So okay, so what is the choroid plexus once again? Choroid plexus. What is the choroid plexus, please? Choroid plexus. What do you mean by choroid plexus? Okay. So it's a specialized or modified ependymal cells. And where are these choroid plexus present? In which ventricle? Okay, lateral ventricles. Okay, so most problem, and so the thing is, right, so the thing is, these ependymal cells, they're most abundant in the lateral ventricles and they're most abundant in the fourth ventricles. Okay, so as a reason, these tumors are mostly found in the fourth ventricles. And once again, if they are found in the ventricle, will they cause hydrocephalus or will they not cause hydrocephalus if they are growing in the ventricles? Yes or no? Will cause hydrocephalus, because if they're growing in the ventricle, they will disrupt the flow of CSF. So they will cause hydrocephalus. And what will happen is you have characteristic perivascular pseudorosettes. Again, a pseudorosette. Okay, so these are perivascular pseudorosettes. So perivascular meaning this is a blood vessel and the rosettes are surrounding the blood vessels. Over here, they are surrounding it. So it's perivascular pseudorosettes, okay, and they're rod-shaped blepharoblast, that's what it is. And these things are rod-shaped, okay, these things are rod-shaped, okay. Okay, now we will come to our story before we move forward, because the next one is easy to understand. Okay, so do you guys, do we have any students over here who is a huge fan of Simpsons? Have you guys watched Simpsons? Simpsons, the cartoon? Anyone? Okay, who else? Anyone? I'm pretty sure we have a lot of mothers over here who has children, and I'm pretty sure you have watched, you were a kid, or you have watched it. Okay. Okay, so do you guys know the main character from The Simpsons? Homer Simpsons. Homer. Okay. So is there anyone over here who not know who Homer Simpson is? Because if that's the case, then my mnemonic will not work. Do we have anyone over here who do not know who? Okay. So Dr. Khatun, would you be kind enough to go to Google and write Homer Simpson? I'm pretty sure if you write Homer Simpsons and you see the character, it's so famous. I'm pretty sure this will come in your this will come in your conscience. You will realize. Are you okay? Are you done writing Homer Simpsons on Google? Dr. Dahlia, okay. Do you recognize the character? Okay, congratulations. Okay, good. So that's what it is. So that's Homer Simpson. And if you have not watched Simpsons in the past, you should really start watching Simpsons in the past. You should really start watching Simpsons right now, because Simpsons, they're doing a very good job in predicting the future. Okay, everything that they say in the cartoon comes to life. I'm not sure if you guys are well acquainted by that or not. Okay, so everything they talk about in the cartoon, they actually comes to life. They talked about our president being the president. I mean, Donald Trump being a president in the cartoon back in 2014 and 15. And for some reason, this came true. And absolutely, we have no idea why. So that's what it is. Okay, so if you know more about your future, watch Simpsons. Okay, right. And even the death of Kobe Bryant, they even said that in the Simpsons cartoon. And for some reason, that also came true. Okay, so that is extremely scary. So I stopped watching Simpsons, but I recently started watching Simpsons again to know more about my future. If doing my residency is actually needed, because if the world ends, then there's no point of studying so much. Okay, okay, so that's what it is. So Simpsons. Okay, so that's what it is. So the thing is, I wanted to talk about Simpsons over here because in medulloblastoma we have Homer right rosettes. Okay, so what I like to think is this is Homer. What I would like to think is, one second. Okay. Okay, what's going on over here? Okay, so what I would like to think is this is Homer. This is the head of Homer. Okay, so Homer is over here. Homer has one hand over here. Homer has another hand over here. Okay, these are the legs of Homer. In this hand of Homer, Homer is holding a rose. Homer came back home. Homer is home. He bought a couple of roses for his wife Marge. Okay, so Homer is here. And in another hand, he has a rod. Why does he have a rod? He has a rod because he wants to beat the crap out of his son Bart. Okay, so what did we draw over here? So we drew Homer. Homer is over here. Homer is holding a rose for his wife Marge in this hand, and holding a rod to beat his son Bart. Okay, so with this mnemonic, what we will do is Homer over here will help us remember that medulloblastoma has Homer right rosettes. Homer right rosettes. So Homer right rosettes are small blue cytoplasm that is over here. Okay, and the fact that Homer is holding a rose on this one, that is the one above medulloblastoma, pilocytic astrocytoma. This will help us remember that the fibers over here are Rosenthal fibers, meaning rose-like fibers. And once again, rose-like fibers are eosinophilic corkscrew fibers. Okay, and another one over here, the Homer is holding a rod because he wants to beat Bart. So it is a rod-shaped blepharoblast. Rod-shaped blepharoblast. Okay, so these are basically perivascular pseudorosettes for ependymoma. Ependymoma, perivascular pseudorosette. So once again, this is the rose which Homer was holding, Rosenthal fibers. This is Homer himself. Okay, small blue cytoplasms. Okay, Homer right pseudorosettes, and the rod which Homer was holding are rod-shaped blepharoblasts, which are surrounding the which are surrounding the vessels. That's what it is. So once again, pilocytic astrocytoma, they're most common in the posterior fossa. Okay, medulloblastoma, they're more common. They're more common where? Okay, in the cerebellum and over here. That this is the ependymoma in the fourth ventricle. Are we clear about the mnemonic? All right, we did this with neuroblastoma, but it was bomb in the other hand. That is correct. Okay, that is correct. I remember this. Okay, so thank you, Dr. Medulla, for making us remember. We did another one of Homer before, where Homer was holding a bomb. That was correct. Okay, that's good. So that's what it is. So for pediatric brain tumors, we have our Homer Simpson holding rose in one hand and a rod in another hand. Okay, so these are the three main tumors. Okay. Okay, next one. Next one is craniopharyngioma. This is very easy to understand because it's a supratentorial tumor once again, and it's in more or less the same location as pituitary adenoma. So this can be confused with pituitary adenoma because it can also cause bitemporal hemianopia because it causes the pressure on optic chiasm. Okay, and these tumors, they are derived from Rathke pouch, ectodermal Rathke pouch. Okay, and they are motor oil-like fluid within the tumor. So within the tumor's craniopharyngioma, you have this oil-like fluid, motor oil-like fluid. Okay, that's what it is. The motor oil-like fluid, and this is known as craniopharyngioma. Okay, and that's that. And this is very easy to understand. Basically, craniopharyngioma is the same thing more or less as pituitary adenoma, and the difference is they are derived from the remnants of Rathke pouch. Okay, so always remember remnants of Rathke pouch is for craniopharyngioma, not pituitary adenoma. And if you have a remnant from Rathke pouch, they will have a motor oil-like fluid within the tumor. Okay, that's that. Okay, last one is penioloma, meaning the pineal gland. Okay, we have a pineal gland over here. So the pineal gland, what this can cause is the tumor over the pineal gland can cause Perinaut syndrome. We talked about Perinaut syndrome in the past, how this can cause a vertical gaze palsy, then third ophthalmic, okay, third cranial nerve palsy, okay, and then light near dissociation, lid retraction, okay, left right disorientation. We talked about this in the common brain lesions. And in penioloma, you have the Perinaut syndrome. Along with this, you can also get compression of the cerebral aqueduct in precocious puberty in males. Okay, and this is known as penioloma. So it's also similar to a germ cell tumor, which is testicular seminoma. The most common way you will receive questions about penioloma is they will tell you about Perinaut syndrome first. How will they discuss or describe Perinaut syndrome? They will describe a patient who has vertical gaze palsy, light near dissociation, lid retraction, and then third ophthalmic nerve palsy. And if they ask you what tumor is causing obstruction, the tumor is known as penioloma. Okay, penioloma. Okay, now what we will do is we will study the mnemonic that we have made for childhood brain tumor. Okay, and so I had one mnemonic in my mind which works for myself, but I'm not sure how much it will work for you. Is there any way you guys can come up with your own mnemonic? Let's see if anyone has any idea. That way we can also have a little bit of fun. PMECP. What's the best mnemonic you can come up with? PMECP. Anyone? Anyone with a big fan of coming up with mnemonics? I mean, we will use them. We also used one of the mnemonics made by, I remember it was Dr. Uday, who came up with a mnemonic in the past about one thing, and we used that. Okay, do we have any other student over here who is interested in making a mnemonic? Anyone? Yes, no? Okay. Okay, playmate ending causes pain. Okay, so if a playmate dies, so playmate ending causes pain. What is this? Basically, if your playmate dies, let's say you have a child who is playing with another friend, and if that friend passes away, it will cause pain to the child. So playmate ending causes pain. And the reason why I did not want to share this mnemonic is because this is a pretty dark mnemonic, and also the fact that it's I personally find it stupid and annoying. But this is the best thing that we could. So that's that. Okay. If you guys have anything else that you can come up with regarding PMECP, you are more than welcome to do so. But do whatever you have to do. Make whatever mnemonic you have to make, but please make sure that you remember PMECP. Why is this important for you to remember? Because Every morning, children passionately eat pancakes. That is brilliant. Okay. Every morning, children passionately eat pancakes. Okay, I think I said pancreas before. That would be weird. So every morning, children passionately eat pancakes. That is absolutely brilliant. So we can use this. Okay. E for ependymoma, M for medulloblastoma, and C for craniopharyngioma, P for pilocytic astrocytoma, E is nothing, and then P again for pinealoma. Okay, this also works. Okay, so please refrain from using mnemonic, okay, but use EMCPP. But the reason why I want you guys to use my mnemonic over here, PMECP, is I want you guys to remember the order. Okay, the order 1, 2, 3. Why is this order important for you to remember? Because the diagram is associated with the order. Okay, if you're not sure about what the brain tumors are, okay, so all you have to do is write P, M, E, C, P, and then draw Homer over here, lying down with a rose, okay, and Homer, another hand, lying down with a bat. Okay, and this is the order I want you guys to remember, although the one that is created by Dr. MS is absolutely brilliant, but playmate ending causes pain is also important because I want you guys to remember the order. In this order you have to remember, because if you remember if you remember it in this order, then you can answer the histological questions associated with the tumors very easily. So that's that. Is that clear? Yes. Are we clear on playmate and causes pain? Why it's important to remember it in one order, in this order. Okay, so that you can place Homer over here, and then the rose over here, and then the rod over here. Okay. Okay, so are we done with the brain tumors? Please make egg croissant for Paul. Okay, look, that is brilliant. Okay, so that makes things very easy. Okay, so please make egg croissant for Paul. Okay, that's what it is. Okay, so PMECP, playmate ending cause pain, is so much worse. Okay, please make egg croissant for Paul is so much better. Okay, so we can also use the one provided by Dr. Hassan. Okay, that's also brilliant. So you guys can use that. Okay, so can we do a fast revision of all the brain tumors before we move on? Good. Let's start. Okay, so first of all, okay, before we do that, can we get one or two doctors who would be interested in doing first of all, let's take one or two doctors who would be interested in doing an active participation for childhood brain tumors only. Childhood brain tumors. Please take 1 minute to read the childhood brain tumors and then answer the questions. Whoever is ready, please say yes. Is anyone ready in doing the revision of childhood brain tumors? I will give you guys exactly 1 minute, please. And I would really, we would really appreciate it if any one of you guys who have not participated before take part in active participation. Anyone? Okay, Dr. Hussam, you can. Anyone else who has not participated before? Dr. Maheshwari, even you participated before. So we would ask you guys if no one else is trying to participate, because I would like to give some chance to all the other doctors who has not participated before. Anyone else, please? This will be your help. This will be of help, because if you participate actively, then you can be a judge whether your understanding of primary pediatric brain tumors are done or not done. Anyone else? Okay, Dr. Nikki. Okay, good. So you have not participated before. So, okay, so would you be kind enough to participate? Yes or no? Okay, good. Okay, so would you be kind enough to unmute yourself and answer the questions regarding primary brain tumors, of pediatric primary brain tumors? Okay, so so would you be kind enough to please tell us which is the most common primary pediatric brain tumor?
Polycystic cytoma.
Okay, good. Which is the, what can you expect to find in the histology of medulloblastoma?
Medulloblastoma, Homer right rosettes.
Okay, and what can you expect to find in the histology of pilocytic astrocytoma?
Rosenthal fibers.
How about in the histology of ependymoma?
Soda rosettes.
Okay, so what was Homer holding in each hand?
A rose
And?
and a rod.
Okay, good. So you would also see rod-shaped blepharoplasts on ependymoma. Okay, so basically that's all I wanted to hear, to see if you guys can remember the histology. And thank you so much, Dr. Nikki, for performing. So that's exactly what it is. Okay, so if you guys can remember the story, and okay, and we have the mnemonic. Okay, so once again, what is the mnemonic for adult primary brain tumors? Adult primary brain tumors. What is the mnemonic? What is the mnemonic for adult primary brain tumors? Okay. What is for tumors? Okay. Playmate ending causes pain, or another way by Dr. Hassan, which says, please make a croissant for Paul. Okay, so that's it. So that's what's so we are done with the adult and pediatric brain tumors. Was that easy for you guys, or was that hard for you? Was that easy or hard? Okay, we can only assess if it was easy or if it was hard if we ask questions and see how fast we get the answers from. Okay, first of all, the questions. Number one, what is the histology of glioblastoma? What is the histology of glioblastoma? Fast question, fast answer, please. Histology of glioblastoma, central necrosis, and pseudopenicillin tumor cells. Next one is oligodendrocytes, for our friend Ollie, who likes to have what? What is the histology of oligodendrocytes? And why is that? Okay. Next, meningioma, which is more common in females. Okay. What do we see in a patient with meningioma? Whorl patterns. That is very good. Okay. What do we see in a patient with hemangioblastoma? Hemangioblastoma. What do we see in a patient with hemangioblastoma, which is a blood vessel, good thin bloods and minimal intervening edema. Next one is, what do we see in a patient with pilocytic astrocytoma? pediatric astrocytoma, Rosenthal fiber. What do we see? A patient with medulloblastoma, hemorrhoid pseudorosets. Would find it with rod shape, blast sets. Okay. Okay, are you guys confident now? Okay, good. That is very good. Okay, so you guys should be confident. Okay. Last one is what is the name of the tumor that is present in that can cross the corpus callosum in adults? Okay, that is present in the frontal lobe in adults. Okay, tumor has a tail. Tail. Which tumor has a tail? Okay. Tumor has which tumor is present in the fourth ventricle in children? Okay, tumor is in the cerebellum, and it is highly aggressive. Medulloblastoma. Okay, good. That's very good. Okay, so okay, you guys should be extremely confident right now, and if you guys have to answer questions regarding the tumors. Okay, so do we have any questions regarding brain tumors before we move on? Do we have any questions regarding brain tumors before we move on? Okay. Okay, next one. Next thing which we are going to study about is we're going to study about herniation syndromes. Okay, so herniation meaning what? The movement of an organ or part of an organ from its normal anatomical position to an abnormal anatomical position, causing pressure symptoms. Okay, so we have moved on to herniation syndromes. Okay, so we have moved on to herniation syndrome. So first of all, what is the first type of herniation that we can see over here? The first type of herniation that we can see over here is a cingulate gyrus herniation, or a cingulate herniation under the falx cerebri. That's under the falx cerebri. So what's happening is basically falx cerebri is basically the covering of the cerebellum, is basically the covering in between the cerebellum, and the cingulate gyrus, meaning this gyrus over here, has herniated either due to trauma or either due to a tumor or either due to a hematoma or anything which is causing pressure, has moved the cingulate gyrus all the way through over here, and the artery that is over here. What is the artery that is present over here? Okay, we talked about that this is a certain artery, this is an artery. Which arteries are present over there? ACA. So there is ACA. So if you have a cingulate gyrus which is herniated over here, they will compress an artery known as anterior cerebral artery. And if you compress anterior cerebral artery, what are the symptoms that you would be seeing in your patient? And urinary incontinence. Very good. Urinary incontinence. Okay, very good. Next one. Next one is if you have a patient who has central or transtentorial herniation, meaning that the herniation is transtentorial, that the tentorium cerebri was over here and the herniation is through over here. Okay, so there is a central or transtentorial herniation. So what happened was this put pressure on the brainstem. Okay, this put pressure on the brainstem, and this results in a rupture of the basilar artery. Okay, so if you have a herniation which is going down, it puts pressure on the brainstem. If it ruptures the basilar artery, what type of syndrome did we talk about? This will happen. Locked-in syndrome. Very good. That's exactly what it is. So that's exactly what will happen, and it's usually fatal. So transtentorial is pushing down on the brainstem. Cingulate herniation is pushing against the anterior cerebral artery. Next one is an uncal herniation or transtentorial herniation. Okay, so this is very important. So this is what happened is there's a medial uncus is the medial temporal lobe. So what happens is there's an early herniation. Okay, meaning that in the earlier times of herniation, that let's say the herniation has occurred right now, okay, there will be an ipsilateral blown pupil. Okay, there will be an ipsilateral blown pupil and contralateral hemiparesis. So if this is the part which is herniating, then this will push on the oculomotor nerve, okay, and this will cause the same side. Let's say this is the right side, okay, and let's say this is the left side. So if the herniation is occurring on the right side in the early stages, it will cause right-sided pupillary dilatation and left-sided paralysis. Over time, what will happen is, okay, so first of all, this is known as, okay, and over time, what would happen is, in early herniation, once again, there will be same-sided blown pupil or dilated pupil and contralateral paralysis. And in later stage, this will result in coma. Okay, this in later stage, this will cause coma. Okay, okay, and there's another phenomenon which you have to get associated with. This is known as Carnohan phenomenon. Carnohan phenomenon. So there's a notch that is known as Carnohan's notch. Okay, so what happens is, if there is contralateral pupil, meaning that if the herniation has occurred on this side, but for some reason the pupil is dilated on the left side, and there is a right-sided paralysis, which is the complete opposite of what we have just said for transturial herniation. This type of phenomenon is known as Carnohan phenomenon, meaning that there is a notch on this side. So for pressure, instead of causing the sign symptoms on this side, the pressure is causing the brain to push on the Carnohan's notch, and this pushing of the brain is causing damage of the oculomotor nerve, and then you have the blown pupil on this side and paralysis on this side. Okay, once again, to avoid confusion, we are talking about transtentorial herniation. Transtentorial herniation is this one. First of all, if it's a transtentorial herniation, this will cause pressure on the oculomotor nerve on the same side, which will cause, for example, if it's a right side, it will cause right-sided pupillary dilatation, and it will cause a left-sided paralysis. But for some reason, if it does not put pressure on this side, it can put pressure on this side, and then this side, there's a notch called the Carnohan's notch. Okay, so this notch over here, this is known as the Carnohan's notch. Okay, so this is a small notch where they press the brain structures, and over there, pressing on the brain structures, what this does is, right now, this causes pressure on the left-sided oculomotor nerve and right-sided white matter. So these patients get Carnohan's phenomenon, which is left-sided blown pupil and right-sided paralysis. Are we clear about transtentorial herniation? No problem, Hassan. Okay, you can leave. Okay, next one. Okay, next one. Okay, so this is the Carnohan's notch, as you can see over here. Okay, okay, next one. Next one is cerebellar tonsillar herniation. So next one is cerebellar tonsil. So we know that the tonsils of the cerebellum, if you have a trauma to the head and there's blood accumulation, for example, in a hematoma or in a subdural hematoma or an epidural hematoma, if it pushes on the cerebellar tonsils, and if the tonsils of the cerebellum they go down, what this will do is this will go and push on the brainstem, and the brainstem has the respiratory center. Okay, so if the tonsils go and push on the brainstem and the respiratory centers do not work, then the patients can die. The patients can have coma and death when these herniations, they compress the brainstem. Okay, so we are done with the herniation syndromes, my bad, syndromes, okay? So first of all, let's do a recap. Okay, please feel the need to unmute yourself and answer this. We can move forward very fast, okay? Okay, what is the name of this herniation in which the cingulate gyrus has moved to over here? Fast answers, please.
Cingulate.
Excuse me?
Aphasia or singular.
Cingulate.
Cingulate herniation. What is the artery that is compressed?
Anterior
Cerebral
cerebral
artery.
Okay, what are the sign symptoms of compression of anterior cerebral artery?
Lower
Lower
limb
limb
weakness and urinary
urinary
incontinence.
incontinence.
Okay, good. Next one is, what is the name of this one? This herniation in which there is a central or downward transtentorial herniation. What is the name of this herniation?
Central herniation.
Okay, which structure is it pressing on?
Basilar artery rupture.
Brainstem.
Brainstem or basilar artery. What is the name of the syndrome as a result of pushing on the
Lock syndrome.
locked-in syndrome?
Locked-in syndrome.
Now we will talk about a very important one, that is this one. Okay, what is the name of this herniation?
knuckle
Transtentorial.
Transtentorial herniation.
Transtentorial or uncle herniation. Okay. What are the sign symptoms of transtentorial herniation? If it's a right, if it's a left.
ipsilateral. Early, it will be ipsilateral body, ipsilateral face and contralateral body.
Ipsilateral blown pupil and contralateral body. And in the late phase, this will cause coma. Okay. Now, if you have transtentorial herniation and it pushes it pushes against the Carnahan's notch over here, what is the name of the phenomenon?
Carnahan phenomenon.
Okay. What is the Carnahan's phenomenon?
Same name of notch.
Okay, one second. What would happen on the left-sided pupil in Carnahan's phenomenon?
It's going to be okay.
Dilated pupil. And how about the right side?
Weakness.
Okay, normal.
Okay.
Normal.
Very good. Next one is what is the name of this herniation?
Cerebral tonsillar herniation.
What is the complication?
Commandus.
Okay, why?
Brainstem herniation.
Compression of brain stem.
Respiratory center.
Okay, thank you so much. So that's what it is. So that's your. Okay, so that's that. Okay, so these are your herniation syndrome. Once again, this is cingulate herniation, pushes on anterior cerebral artery. Next one is downward herniation, which pushes on basilar artery. Then you have transtentorial herniation, which can cause ipsilateral blown pupil and left and contralateral paralysis. Or if it pushes on the Carnahan's phenomenon, even the trauma, even if the trauma is over here, but the symptoms have become opposite, meaning that there is contralateral pupillary dilatation and ipsilateral paralysis. Okay, this is known as Carnahan's phenomenon. And the last one is tonsillar herniation, in which the patients have brainstem compression and respiratory depression. That's it. Okay. Are we good on the herniation syndromes? Yes, no? Okay, perfect. Okay, so are you guys well acquainted with upper motor and neuromotor and lower motor neuron lesions? Okay, what is motor neuron lesion and what is lower motor neuron lesion? Okay, first of all, this is the brain. Okay, I'm sure you guys know exactly what I'm talking about. Then, okay, then this is the spinal cord. Okay, and then this is your hand. Okay, so if you have structures coming through here, synapse, very roughly drawn, and then structures coming to here. Okay, I mean structures, by structures I mean nerves. Okay, 1, 2. Which one of this is the upper and which one of this is the lower motor? Okay. Else? Okay, so this is very easy basic knowledge, meaning that the nerves that are emerging from the cortex to the spinal cord are upper motor neuron nerves, and the nerves that are coming from the spinal cord to the muscles are lower motor neuron nerves. Okay, have you heard of the fact that the upper motor neuron has an inhibitory action on the lower motor neuron? Yes or no? Okay. What upper motor neuron, they try to inhibit the impulses of the lower motor neuron. Okay, so basically what happens is you have an older brother. Okay, you have an older brother and you have a younger brother. Okay, so for all the students who are mothers over here, and I'm sure if you guys have sons, then you guys know that if you have two sons, the usually the first child or the older child tries to inhibit the lower child, meaning that the lower child is always very naughty and tries to roam around the house and stuff, and the older child always tries to discipline the younger child. and ask them to not roam around, to not do this, not do that. That is the same function of the upper motor neuron. The upper motor neuron, what they do is they try to inhibit the lower motor neuron, right? So over here, this is more or less the same function. So if you have damage of the upper motor neuron, will there be increased function of the lower motor neuron, or decreased function? If you have damage upper motor neuron, will there be increased working of the lower motor neuron, or decrease working of the lower motor neuron? Increase working of the lower motor neuron. That's what will happen. Okay, so there will be increased working of the lower motor neuron. So what would happen is what would happen over here is, so okay, so let's talk about these things right now. Okay, so the main point was, if you have an upper motor neuron lesion. So okay, so let's take spastic paralysis, for example. Okay, we know that in spastic paralysis, if we have an upper motor neuron lesion, okay, so let's say the upper motor is not working, so there's a spastic paralysis, meaning that the paralysis is spastic. Now the lower motor neuron is working more, because the upper motor neuron tries to inhibit the lower motor neuron, so that is not happening. As a result, the lower motor neuron now is causing more impulses to go, and this can cause a spastic paralysis. Same way, if there is a lower motor neuron lesion, if it's a lower motor neuron lesion, meaning the lower motor neuron is not working, the paralysis is known as flaccid paralysis. Okay, so there is flaccid paralysis, or flaccid paralysis over here. That's the same thing. So right now the lower motor neuron is not working, the upper motor neuron is causing inhibitory action. Next one is clasp knife spasticity, meaning that clasp knife spasticity. Do you guys know what clasp knife spasticity is? Clasp knife spasticity. Okay, so basically this means that movements are very taut, or very so it's if it's like if it's a hand, okay, it will be extremely difficult to bend the fingers. So this is known as clasp knife spasticity. So once again, a spastic type of movement that is due to upper motor neuron. Why? Because the upper motor neuron used to inhibit the lower motor neuron, and now since the upper motor neuron is damaged, the lower motor neuron is working more. Okay, same thing goes for tone. If there's an upper motor neuron lesion, there will be more tone. Why? Because the upper motor neuron cannot inhibit. Reflexes are also increased in upper motor neuron lesion, because the upper motor neuron cannot inhibit the reflexes. As a result, the reflexes are increased. Okay, and what happens is fasciculation. What are fasciculations? Fasciculations are basically, what happens is, if you, let's say this is a muscle, let's say this is the bicep muscle, okay, and if you tap the bicep muscle, very gently, the bicep muscles will start contracting. And why? This is due to excess amount of stored acetylcholines over here. Why is the acetylcholine stored in fasciculations for lower motor neuron lesions? Because in lower motor neuron lesions, since the lower motor neurons cannot work, okay, since the lower motor neurons are damaged, the upper motor neuron is releasing acetylcholine, which goes and tries to stimulate the lower motor neuron. But for some reason, since the lower motor neuron is damaged, either due to trauma or due to any other demyelination disease, so the neurotransmitter goes and it accumulates in the synapses. Okay, and when you put pressure from outside, for example, a tap, this acetylcholine enters the muscle, and this causes muscular contraction. This is known as fasciculations. Okay, next one is atrophy. Atrophy is basically more seen in atrophy, meaning decrease in the size of the muscle. Atrophy is seen in lower motor neuron lesion. Why? Because loss of innervation of the lower motor neuron results in loss of function. Always remember, if there was an upper motor neuron, then the muscle would contract and maintain its hypertrophy. So since there is loss of muscular contraction with lower motor neuron lesion disease, there is atrophy. And weakness is the same in both upper motor neuron and lower motor neuron lesion. The weakness is the same in both. Okay. Another one is Babinski sign. And we talked about Babinski sign. Babinski sign is basically a sign of upper motor neuron lesion, meaning that it's a re-emergence of primitive reflexes. Okay. So if there was an upper motor neuron lesion, meaning that the brain is not functioning properly, the brain forgets that it has learned to walk. I mean, do you guys remember how I told you that Babinski is when the young babies, they try to fan out their toes and extend the great toe because they do not want to stand in the ground. but as the baby gets older, they try to make a grasp on the floor, and that's how we walk as adults. We are not afraid of the floor, so we do not take our feet away from the floor. But young babies, they take their feet away from their floor, and this type of re-emergence of young baby signs in adults are your signs that the adult has forgotten his learned reflex. And this is happening because there is damage to the brain, and this is an upper motor neuron lesion. So there's an upper motor neuron lesion over here. So that's exactly what it is. Okay, so with that being said, I have broken down all the informations about the upper motor and the lower motor neuron signs. I will give you guys 1 minute to read this, and I will test whether you guys have understood why and what is happening. Anyone who is we have a couple of students over here who has never participated. Okay, I would really appreciate if you can participate and see whether you have understood the text or not. Okay, so okay, I'll give you guys 1 minute to learn this right now, since I have just discussed and broken everything down in details. I want you guys to read this right now and tell me the answers. Okay. Okay, good. So can we have the first physician, Dr. Iman?
Yes.
Okay, perfect. Would you be kind enough to tell us what happens to weakness in upper motor and lower motor neuron lesion?
There is weakness in both.
Okay, there's weakness in both. Okay, next one.
Yeah.
What happens to atrophy?
Atrophy in lower motor neuron only.
Very good. Well, what about fasciculations?
In lower motor neuron.
Okay, thank you so much, Dr. Iman. Next one goes to Dr. Hussein.
Yeah.
Okay, would you be kind enough to tell us about the reflexes, where it's increased and where it's decreased?
Increase in upper motor neuron and decrease in lower motor neuron.
Okay, perfect. Next one is Dr. Mridula. Would you be kind enough to tell us how the tones are changed or changing in upper motor and lower motor neuron lesion?
Tone is increased in upper motor neuron lesion and decreased in lower motor neuron.
Okay, perfect. What can we ask the next physician, Dr. Abed Sheikh Yusuf?
Yes.
Okay, doctor, would you be kind enough to tell us what would happen to spastic paralysis in upper and lower motor neuron lesion?
It's more in upper motor lesion, and it's
Okay.
absent in lower.
Perfect, thank you. And what is the next one is, where do you see more of flaccid paralysis?
Spastic paralysis in flaccid in lower.
Okay, thank you. Okay, so are you the brother of Dr. Hussam?
Yes.
Okay, perfect. Your brother is an excellent physician, and so are you. Thank you so much for participating and coming to our lectures. Okay, next one is let's go to Dr. Dahlia. Would you kind enough to where do we see more of clasp knife spasticity?
In upper motor neuron.
Perfect. So with that being said, thank you so much, Dr. Dahlia, for forming. And that's that. Okay, so that's what it is. Okay, so these are all the motor neuron signs, and we are done with the motor neuron signs. Okay, now we will move on to spinal lesions. Okay, once again, spinal lesions. Protein myelitis. Okay, come on. Okay, so today or tomorrow, which one? Because you wrote notes. Which one do you guys want to do? Spinal cord lesions. Tumors were draining. Okay, let's do your notes for today. Okay, does agree? Okay, break. Okay, so spinal lesions, we will start with the spinal lesions tomorrow. Okay, we will start with lesions tomorrow, and that's what it is. Okay, with that being said, let's take a small break of let's say 5 minutes. Okay, let's take a small break for 5 minutes, and then we can come back and do the URL notes. Okay, okay, perfect. Okay, do we have Dr. Mazar Yusuf over here? Dr. Mazar Yusuf? Okay, Dr. Yusuf, is your email M's Creation? Okay. Would you be kind enough to give us a reply on our email? We sent you an email most probably yesterday. Dr. Yusuf, would you be kind enough to give us a reply on our email? Okay, thank you. Okay, do we have Dr. Ibrahim, Dr. Sarah Ibrahim over here? Dr. Sarah Ibrahim. Dr. Sarah Ibrahim, do we have you over here? Okay, Dr. Sarah Ibrahim, is your name Dr. Is your email or is your name, um, one second, please. Is Hussein Sarah, is that you, Hussein Sarah?
Yes.
Okay, perfect. Thank you so much. Okay, so the names have been a bit confusing for all of us. Okay, thank you so much. That's all we wanted to know. Thank you. Dr. Uday, we received your message and thank you for replying. That makes things very easy for us. Thank you so much. Okay. Okay. If everyone is back from their break, we are ready to begin. So if everyone is back, could you please let me know so that we can start, because we do not want to waste any more time because we have to do questions today. Okay, 5 minutes is still not over. So we will wait, no problem. Once you guys are back, then we will start. Okay. Do we have any student over here who has not joined the Facebook discussion group? Do we have, okay. So let me share the, okay, let me share. Okay, wait 1 second. Okay, so please send us an invitation to enter the Facebook discussion group and we will add you to the group right now, Dr. Khatun. Okay, and we have already posted the notes for UWorld to the group. So that's that. Okay. Okay, so we have already posted the UWorld notes from yesterday to the group. Okay, so is everyone back from their break, please? Okay, good. So since everyone is back from the break, we can successfully start our UWorld notes discussion. Okay, we can successfully begin our UWorld notes discussion. That's what we will do. Okay. 1 second, let me see if you guys can share the screen. Okay. Okay. Okay, so can you guys see my screen? Can you guys see my screen? Yes or no? You guys can unmute yourself and answer because right now I will not be going back to the chat box.
Yeah.
Okay, perfect. So let's begin with our UWorld notes for today. Okay. First of all, the first question that I want to ask you guys, and let's say you have patients So in patients with panic attack, okay, what are the changes in partial pressure of carbon dioxide, cerebral blood flow?
Carbon dioxide will be decreased due to
decreased.
hyperventilation.
Okay. What about the cerebral blood flow?
Decreased.
Decrease.
Why?
Hypertension.
Due to hypertension.
High.
Because
we say
decrease.
Adrenaline.
Cerebral perfusion pressure.
Because CO2 decreased. We
There we
agreed that CO2 regulates the blood flow.
That is absolutely correct. So it's dependent on cerebral. It's dependent on partial pressure of carbon dioxide. So that's that. So that's what.
Yeah, increase.
Okay, next one. Next one. Have you guys heard about carbon tetrachloride?
Yes.
Okay. What damage does carbon tetrachloride do to the hepatic parenchyma? How does it cause the damage? How does it cause the damage? Not the histology.
It metabolized or something.
Okay.
Okay,
good. Next one. Next one is, okay, in esophageal variceal bleeding. Esophageal variceal bleeding. Okay, there is increased pressure in which vein? For which there is a variceal bleeding?
Left gastric.
Left gastric. Left gastric vein.
Left gastric vein. Okay, in left gastric.
Left gastric
vein. Okay. Next one. Next one is if you have an okay, 1 second. Okay. Have you guys heard about cystine stones?
Yeah. Yes.
Okay, good. In cystine stones, what is the urinary increase in which substances are increased in the urine for cystine stone?
pH.
Lysine, we have.
Isolysine and lysine.
Ornithine.
Okay. Increase.
Ornithine, lysine, arginine.
Cola.
Very
yeah,
good.
it's cola.
Increase cystine, ornithine, lysine, arginine. Okay. Okay. Why? Why?
Because same transporter of amino acid.
Okay, because due to decreased renal reabsorption of cola due to same transporter. Okay, very good. Next one. Okay. Increased blood pressure. Adrenal mass, but low renin. Okay, this is very difficult, but very easy. What is the name of this mechanism in which the blood pressure is increased, but renin is low due to an adrenal mass?
Conn's syndrome?
Nope.
Pheochromocytoma?
No, I'm not talking about I'm not talking about the pathology. I'm talking about a mechanism in which the renin stays low, but the blood pressure is still increased due to an adrenal mass. Okay, another thing.
Maybe pheochromocytoma or neuroblastoma.
What is eunatremia? Now, what is the name of the mechanism in which the
wasting
appropriate ADS secretion?
Aldosterone wasting. Escaping.
Okay. What is the hormone responsible for aldosterone escape?
A and B.
Okay. Have you guys heard about vasospastic angina? And I know you guys have heard about it.
Yeah, Brenz metal.
Okay. Vasospastic angina. What is the pathophysiology?
Clamping down.
Vasospasm of
Vasospasm.
coronary artery.
Is there hyperactivity or no hyperactivity?
Hyperactivity of alpha receptors.
Hyperactivity of?
Alpha receptors, alpha 1.
Okay, as a result, you have hyperactivity of vascular smooth muscle due to what Dr. Hossam just said, due to endothelial dysfunction and autoimmune imbalance. Okay, that is vasospastic angina, and also due to hyperactivity of the alpha 1 receptors. Okay, good. Okay. Okay, 1 second. One second, please. Okay, let's wait for this to come. Let's move on to the next question. Okay. Have you guys heard about DRESS syndrome?
Which syndrome?
Have you guys heard about DRESS syndrome? What is DRESS syndrome? What is DRESS syndrome?
Drug-related
MI.
Not the one with pericarditis.
Pericarditis after MI.
Post
What is
MI.
DRESS syndrome?
is xenophilic also. I'm not sure about that. Breast reaction is xenophilic.
You have the mic on?
Systemic.
Okay. Okay, drug reaction with eosinophilia and systemic syndrome. Okay, so what are the drugs that can cause DRESS syndrome?
Phenytoin, vancomycin.
Number 1 is phenytoin. Thank you. Who is the doctor who just said phenytoin?
Azar.
Okay, thank you. Okay, thank you. So number 1 is phenytoin. Then number 2?
Vancomycin.
Okay, vancomycin. Next. Carbamazepine. Next. Minocycline. Next. Allopurinol. Next. Sulfonamide. Are we clear?
Yeah.
Okay. Okay. Okay, good. Next one. Okay. 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 Have you guys heard about schistosomiasis?
Yeah.
Very good. Okay. What does schistosoma hematobium cause?
Urinary schistosomiasis.
Mesenteric veins or urinary hypertrophy. Urinary bladder hypertrophy.
Squamous cell carcinoma.
Squamous cell carcinoma.
Of
the bladder.
Bladder.
Okay. And how about Manzoni? And
intestinal. CIT. Hematobium.
Liver fibrosis.
Japonicum is liver.
Periportal liver fibrosis.
And what about the intestine?
Manzonine.
Okay, so both of them, what they cause is they cause intestinal and hepatic fibrosis. Okay, intestinal and hepatic fibrosis. Where are they more common, Manzoni and Japonicum?
Africa and Japan.
In Asia.
Asia, that is correct. In Asia. Okay, one second. Schistosoma japonicum is in Asia. Where is schistosoma manzoni? Do we have any students over here from the Caribbean islands? Do we have any
Caribbean.
Do we have any student over here from the Caribbean islands? No.
I'm in the Caribbean island, but I am not from Caribbean island.
Okay, but you are in Caribbean?
Yeah.
Okay, so you can look out for Schistoma manzoni in Caribbeans because it's endemic in Caribbeans. Okay, in the Caribbean island. How about hematobium?
Africa.
Do we have any students over here from the Middle East or Egypt?
Yeah. Yes.
Okay, perfect.
Yeah.
And Sudan, not. In Sudan, you have a lot.
Yeah.
All of us.
Africa and Middle East. Okay. Okay, why am I mentioning the names of the countries? I am mentioning the names of the countries because these are UWorld questions. You will not believe it.
Yes.
UWorld will ask you whether you have the knowledge of the fact that Manzoni is in Caribbeans, Japonicum is in Asia, Hematobium is in Africa and Middle East. Okay, so if you have friends in Middle East and Africa who want to go for swimming in the lake, are you going to warn them about the disease? Yes or no?
Yes.
Yes, you should warn them because they might get squamous cell carcinoma. Okay, next one. Next one is poor feeding, irritability, poor feeding, irritability, and skin erythema. Okay, what is the name of this condition?
Meningitis.
Nope.
Yeah.
Okay, another thing. Nikolsky sign positive.
Pemphigus vulgaris.
Nope.
No.
SSS.
Okay. Fever. Weakness.
Scarlet.
Sepsis. Now, what is the condition?
Look like SSS.
Yeah, skin scalded
There
something.
we go.
Staphylococcal skin pal.
Perfect. It's staphylococcal scalded
Skin syndrome.
skin syndrome. Okay. So the thing is, skin erythema, poor feeding, and irritability. This is very broad spectrum. These are very broad spectrum sign symptoms. Presentations, right? So you have to be very careful when you talk about systemic conditions. That is poor feeding and irritability, along with skin conditions. That is erythema and Nikolsky skin positive. And these two together are a very good diagnosis for staphylococcal scalded skin syndrome. So be aware. Okay, be aware because of that. Okay. So in autoimmune hepatitis, do we have lymphocytic infiltration? Yes or no? In autoimmune hepatitis.
Yes. Yeah.
Lymphocytic infiltration. Yes or no?
Yes.
Yes, doctor.
Dr. Yusuf, thank you for your email. We'll see you. Okay, Dr. Yusuf, thank you for your email. We will review the email and then we'll get back to you. Okay, thank you so much for your prompt response. Okay, we really appreciate it. Thank you so much. Okay, autoimmune hepatitis. Once again, what is autoimmune hepatitis? Okay, this is an autoimmune damage to the liver and the lymphocytic infiltration. Where is the lymphocytic infiltration? That is my question. Where is the lymphocytic infiltration?
Periportal.
Periportal and portal. Okay. Okay, next one. Okay. Okay, 1 second, please. Okay. Let's talk about the different types of cognitive impairments in adults in stages. Okay. Number one is normal aging. Okay. Okay, what do we see in normal aging? In normal aging, as we grow older, what happens? We have decreased fluid intelligence. Okay, then what we have is, okay, then we have is normal functioning of all other activities. Okay, only decrease in fluid intelligence. Okay, next one, number two. Number two is mild impairment, mild cognitive impairment. I'm sorry?
What do you mean by decreased fluid?
Oh, what I mean by decreased fluid intelligence, meaning that, let's say, if you ask a 30-year-old to do a math, let's say you ask the 30-year-old to divide 10 by 3, he will say 3.33333 in, let's say, 1 second. But if you ask an adult 70-year-old, how do you divide 10 by 3, it will take him some time to do the math. So that is decrease in fluid intelligence. Okay. Okay. Next one. Next one is mild cognitive impairment. There will be mild decline in more than one cognitive domain. Okay, it could either be drawing, it could either be writing, it could either be calculation. Okay, so there will be decline in more than one cognitive impairment. Okay, next one. Next one is major cognitive impairment. Okay, so what will happen over here? You will have global cognitive, meaning more than one domain. Global cognitive impairment, functional impairment. Patients will not be able to function. They will not know how to eat, how to perform any action, and severely decreased cognitive domains. Okay, by that I mean they will not be able to perform any task. Okay, they will not be able to perform any task. Okay. Okay, next one. Next one is okay. Next one is, what are the criteria of dementia with depression? Criteria of dementia with depression. Number one, the depression is episodic. Number two, okay. Number two is there. Sorry, episodic dementia, not episodic depression, episodic dementia. Number two, there is signs, symptoms of depression. Number three is reversible.
Improve treatment.
Right, meaning that there is reversible cognitive impairment. Okay, so the cognitive impairment will be reversible. Okay. Okay, next one. Okay, next one is a very, very high yield discussion. Okay, so what I will have is organisms. Okay, number one, genital ulcer diseases. Okay, number one is organism. Then what are the organisms that can cause genital ulcers? That's a question, guys.
Syphilis. Bellis.
Then
Haemophilus ducrei.
Chlamydia. Herpes simplex.
Yeah, herpes. And chlamydia.
Meaning granuloma inguinale, right?
Yeah.
Yeah.
Okay. Okay.
Syphilis painless.
How?
Painless.
Bellis, yeah.
Okay, single or multiple?
Single.
Single.
Painless. How about the margin?
Raised.
Okay. Heaped up. The word is heaped margin or raised margin. Heaped margin. How about The base, is it clean?
Yes.
Yes.
Okay, now we will go to hemophilus ducree.
Painful, single.
Painful. Then?
Single.
Single.
Single, okay. Next?
Virulent. Virulent also.
Will there be lymphadenitis?
Yes.
Yes.
Will there be suppurative or non-suppurative?
Suppurative.
Non-suppurative or suppurative?
Suppurative.
Suppurative.
Suppurative, meaning that there's pus forming lymphadenitis. Okay. Next one is herpes simplex.
Multiple painful.
Multiple vesicles.
Painful.
Multiple.
Then vesicular. Then how about the base?
Red.
Red. Red, meaning erythematous.
Erythematous, yeah.
Erythematous base, yes.
Okay. Next, granuloma inguinale.
Painless.
Painless.
Painful lymph node.
It's at the beginning, maybe
I think no.
painless. Then there is something switch here.
First of all, it's process.
No lymphadenopathy, I think.
Then there's red
ulcer.
Right.
Bleeding ulcers.
Red serpiginous, meaning snake-like.
Yes.
Yeah.
Please, doctor, someone waiting to let him to enter.
Okay. Okay, thank you. Okay. Thank you for letting me know. Okay, so red serpiginous ulcers. Okay, then will there be lymphadenopathy or no lymphadenopathy?
No, no lymphadenopathy.
It's painful lymphadenopathy.
Maybe at the beginning, no, but later, yes.
So yes. So with painful lymphadenopathy. With
Yes.
lymphadenopathy. Okay.
Mm-hmm.
How do you diagnose these things?
Biopsy.
Field.
From the ulcer.
Dark field.
Dark field. And
Check on it.
have you guys heard about rapid plasma reagent test?
Yes.
Yes.
Yeah.
How about venereal disease research laboratory test?
Yes.
Yeah, VDL.
Okay. Next.
VDL.
Okay. Next one. How do you diagnose Dupree?
Again, please.
How do you diagnose hemophilus Dupree? Gram stain
Okay.
and
BCR.
PCR. How do you diagnose HSV?
BCR.
PCR. And what is the name of a smear that we do?
Zach.
smear.
Granuloma inguinale. How do you do the diagnosis?
Special media. So.
First of all, it's gram stain. Your biopsy of the limb. What do we see in the biopsy?
Donovan bodies.
Very good. Very good. What we see is we see Donovan bodies. Okay. Okay, so that's what it is. Okay. Okay. Triad of mid-systolic murmur with slow rising carotid pulse and large pressure gradient. This is a UL question where they said you have a patient with mid-systolic murmurs, low rising carotid pulse, and the pressure gradient is very large. What is your diagnosis?
Aortic stenosis.
Very good.
Yeah.
Okay, very good. Okay. Okay, 1 second. Gotcha. Okay, what is the name of this virus in which the virus is a naked virus? Evil. Okay, naked virus, single-stranded, positive. What is the name of this virus?
Picorna?
No. Okay, picorna could also be it. Okay.
There are multiple with this.
Yeah, it's not
There are-
specific.
There are multiple viruses. What is the name of these viruses? Or how many viruses? Okay, picorna is one, and rhinovirus. And have you guys heard of PARCH? P-E-R-C-H. Picorna, eco, rhino.
Yeah, entero.
Okay, enter. Okay, so we're not going to discuss this right now. We'll discuss
Those
this.
are Picorna family, all of them.
Yes, picorna family. That is good. Okay, so we'll discuss this later when we do microbiology. Next one. Next one is, okay. 1 second. Okay. What are the areas supplied by external iliac artery? This is important. Areas supplied by external iliac artery. Okay, first of all, where does the wide area? Oh, okay, so basically this is a very broad spectrum answer. What are the structures that, which part of the body does the external iliac arteries supply?
Lower limb.
Lower limb. Next one, internal iliac.
Pelvic organs.
Yes.
Pelvic walls and viscera. Okay. Next. Female.
Uterus.
Reproductive organs. Then medial thigh. Then bladder. Okay. Okay. Next one, internal pudendal. Do we have Dr. Adhanom with us today, Dr. Adhanom?
Yeah.
Okay, Dr. Adhanom, you usually say a lot of answers. Why are you so quiet today? Is everything okay? Everything okay? Dr. Adhanom, all good? Okay, everything is good with Dr. Adhanom?
Yeah.
Okay, good. The thing is, usually we have a couple of doctors who always participate. We have Dr. Hussam, Dr. Adhanom, then we have a lot of other doctors, Dr. Imad, all the other doctors who usually. So when we do not hear your voice during our participations, we kind of wait if everything is okay. So hopefully everything is good. Okay. What are the structures supplied by internal pudendal artery? Anal canal. Yes. Scrotum. Vulva.
Yeah.
Next one. Obturator artery.
Muscles.
Pelvis. Bladder.
And femoris bone, maybe.
Femoral head, right?
Yeah, femoral head.
And then once again medial thigh. Okay. Okay. Renal artery. What does it supply?
Renal.
Kidney.
Of course.
And adrenal gland.
No, that was just a joke. Okay, renal artery. No problem. Okay, renal artery supplies kidney. No problem. Okay, next one. Next one. Okay. Dry skin and night blindness. Which vitamin?
Vitamin A.
Vitamin A.
A.
Okay. Okay, histology. Okay, this is a good one. We have studied about this. Histology of Trophirema Weepley.
Pass positive.
What do we see?
Cells.
That's positive.
Pass positive.
PAS positive. Sure, but okay, let's first discuss about the intestinal mucosa. Is there atrophy or hypertrophy of the intestinal mucosa?
Sorry, it was breaking. I didn't.
Atrophy.
Voice breaking? Is the voice breaking?
It's okay now.
Yeah.
Now okay.
Okay. So what about the intestinal mucosa? Is it hypertrophy or atrophy due to chronic
Atrophy.
atrophy? So atrophic mucosa. Okay, next one. Next one is, what about the macrophages?
Increased, I mean, fat laden
In lamina propria.
macrophage.
Yeah, there is.
Laden or foam cells.
Foamy macrophage with gram-positive rod-shaped bacilli with PAS. What is the full form of PAS?
Passive acid.
Periodic acid shift. That is well.
Periodic acid shift.
Okay, and okay. Foamy macrophage with gram-positive rod-shaped bacilli with PAS positive and diastase resistant granules. Okay, granules which are resistant graded by diastase. Okay, next one. Okay, next one. So you have a patient who has been stabbed. So stabbing at left fourth intercostal space at left sternal border. Which compartment of the heart is injured?
Right ventricle.
Right.
Okay. Now stabbing at second space at left sternal border.
Aorta.
No. Anyone?
Right atrium.
No.
Pulmonary one.
Right atrium is
trunk.
the posterior part. Right atrium is not damaged. Okay, pulmonary trunk. Okay. Okay. Penetrating injury at right of vertebra at T8. Which vessel is damaged? Right-sided from the back. If someone gets stabbed from the right side on the back at T8, which one is damaged? The blood is a dark blood.
Left atrium.
Nope.
Inferior
vena cava.
Inferior vena cava. Oh, okay.
Okay. Okay, so these are the UWorld notes for today. Okay, so
Can you just like briefly pass over the psychology, what you said? I didn't get, like water and fluid intelligence, something.
Oh, fluid intelligence. Okay, fluid intelligence basically. Okay, so basically, if I ask you now, Dr. Hussam, what is 12 divided by 4? What is your answer?
Yeah, 3.
3. Okay, so if you ask this same question to someone who is 90-year-old, do you think he will give the same answer in this small amount of time, or will he take more time?
No, more time.
More time. The fact that you answered so quick is you have fluid intelligence, meaning that your intelligence is like fluid, like water, because water is so smooth. Okay, so smooth intelligence, that's what it is. And if I ask every one of you right now, let's say, if I ask every one of you like right now, let's say, how many compartments does the heart have? Well, what is your answer?
Yeah, 4.
Four chambers or 4 compartments, and that answer is so fluid. It's fluid like water, because I ask and I ask you the question and you tell me the answer. So that's fluid answer. And this knowledge or this thing will decrease with age. Okay. By the time you are 75, 85, 95, if you ask someone, let's say you ask a 95-year-old, okay, sir, how many compartments does the heart have? The 90-year-old will say, huh? What? Okay. Okay, 4. See? Okay. So this presentation is known as fluid intelligence. Decrease in fluid intelligence. Okay?
Yeah, thank you.
Okay. Okay. So is everyone okay with the URL notes for today? The last notes. Okay. This is the last notes. Okay. So now we will do some questions. Okay. So thank you so much for staying with us while we did the URL notes. Okay. And so for all the new students who have joined us, I'm pretty sure you have the idea about how our lectures usually go. That is it. Okay, so right now what we will be doing is we will be discussing about how to target UWorld questions. So we will be discussing about some UWorld neurological questions. Okay, does anyone want a small break before we do that? 5 minutes. After that, we'll be done. It only takes us 10 minutes to do 5 questions, more less than 10 minutes. Okay. Okay, 5-minute break, then we can come back. Okay. Okay, is everyone ready? Can everyone see my screen?
Yeah.
Okay. So let's start with our UWorld discussions. Let's see how many students we have.
Yeah.
Okay, we have a little baby with us today. And please give my love and prayers to the little baby.
Yeah, sorry, that is why I'm not sharing.
Okay, no problem. Okay, I personally love little babies. Give my love to the little one. Okay, I just want to see how many students we have with us today. Okay, so okay, we have 19 students. We started with 33. Now we have 19. Okay, no problem. So okay, so this is a proper UWorld question, and this is the type of question you will receive in your actual exam for all the students who have very little idea about the questions. This is the type of questions you will receive, and you will get exactly 90 seconds on the clock to read the question and answer the right answer. Okay, so how do you do that in 90 seconds? First of all, first thing you read, last line. Okay, then have a glimpse of all the answers. Then you start reading from here. Okay, usually what you do, you will use a marker to mark the important things. And once you mark the important things, everything is easy. So first of all, the last line is the pain sensation from his ulcer is most likely carried by which nerves? So you have the names of the nerves. Let's see where his ulcer is. How old is he? The 35-year-old man. Painful, tongue sore, not important. Okay, he had fever, underlying fever, experienced myalgia and arthalgia. Underline this because this can have rheumatological associations. No known medical problem, has been a driver, had unprotected sexual intercourse with a stranger approximately 1 month ago. Okay. Physical examination shows a rash on his trunk and cervical lymphadenopathy, most probably it going towards AIDS. Okay. An ulcer is located on the median sulcus of the tongue and 2 centimeter anterior to the foramen cecum. Okay, so it's anterior. Now, underline this, and now what is your answer?
It's trigeminal mandibular division.
Mandibular division, C.
C, yeah.
Mandibular division of the trigeminal. Easy. Let's see if the percentage of students who has answered correctly. The percentage of students.
We could solve the question from last 3 sentences only.
I'm sorry?
I said like we could solve the question from last 3 sentences only.
Definitely, yes, you can. Okay, so what Dr. Osam has said is you can solve the question from the last 3 sentences only, meaning that if you can only read the last question, an ulcer is located on the median sulcus. So you look at the ulcer and you look at the pain, and that's what it is. But I still ask you guys to read the whole question because there might be some associations which you have missed, okay, over here. So just a glimpse of everything would be okay.
Yeah,
So,
sometimes they trick us.
yes, sometimes they will trick you. So
yeah,
be careful. Okay, next one. Okay, so I will not tell you anything. You will tell me the answer at 124. 123 right now in the clock. Read the question like how I said. By 124, I want my answer. Ready?
Right shoulder pain.
Okay. What is the nerve that is present in between the ribs?
Phrenic nerve.
Trapezius.
Phrenic nerve.
Trapezius.
No,
The
diaphragm.
nerve is
Diaphragm
the
is A.
nerve 11.
Okay, first of all, what is the answer? It's one.
Diaphragm A.
Diaphragm A.
Okay, what did the little baby say? Diaphragm?
Yeah.
Okay, if the little baby said diaphragm, then diaphragm is the right answer. Why? Because the nerve in between the scalene is your phrenic nerve. Okay.
Yeah, phrenic nerve.
Between.
Okay.
I guess this cranial nerve 11, doctor.
No, because he received an anesthesia between the right anterior and middle scalene, not from the sternocleidomastoid and the trapezius.
Yeah,
So
this closer near to this one.
Sternocleidomastoid will be 11th. Are we clear?
Yes.
Dr. Adler?
Scalene's triangle.
Scalene's triangle, yes.
In back of the neck, I think.
Yes, and it's in the back of the neck. The Accessory nerve is in the sternocleidomastoid,
Yeah, yeah.
the anterior triangle.
So
Are we clear?
Yes, yeah.
Yes.
Okay. Do we have any more confusion?
I didn't get the answer there.
Okay, the answer is basically the brachial plexus. It originates from the C5 to T1 nerve.
Yeah.
Okay. And
Yeah.
what it will do is this nerve has 3 branches, right? And the branches of the cranial and the branches of this nerves, what they do is the major branch, it escapes between the scalene, anterior and middle scalene. It escapes in between that. So if there is an anesthesia in between the anterior and middle scalene, this will result in blockage of
Phrenic nerve.
Phrenic nerve.
Uh-huh.
That's what. Okay. And basically the brachial,
Yes.
it controls. Okay, so what they said is they also said that what it is since it's a brachial plexus muscle, the brachial plexus muscle will look what it said. Dr. Adenom, I want your attention over here. Look for blockade of the brachial plexus. Okay, so do you think that the brachial plexus
Yeah.
trapezius? Yes or no?
I thought it was posterior triangle of the
Right,
neck.
but they blocked the brachial
yeah.
plexus. Look, the brachial plexus is not involved in innervating
It's clear, yeah.
the trapezius. The cranial nerve 11 is involved in innervating. Okay, so the answer is not trapezius. Also, even though the the accessory cranial nerve passes through that region, they blocked only the brachial plexus. So the diaphragm is the right answer.
Yeah.
Okay, and you guys want to know the percentage? The percentage of students who said diaphragm was 18%. The percentage of student who said trapezius was 42%. Okay, so the main problem is with this line, blockade of the brachial plexus. Okay.
So doctor, do they mean that the phrenic nerve pass in between these middle scalene muscle and anterior scalene muscle, or because the brachial plexus share the same root?
So the thing is, they share the same root.
Uh-huh.
Okay, and also some small branches passes through the anterior and middle scalene muscle. Okay, are we clear? Can we move on to the next question?
Yeah.
Okay. Okay, perfect. Okay. Fine. The nerve affected was most likely injured at which of the locations? Okay. This is a hard question. So be careful.
Right-handed.
Okay. First of all, which nerve is injured?
Radial nerve.
Radial.
Where is the radial nerve injured over here? So what is the most common location of radial nerve injury?
Mid shaft.
Usually it's mid shaft of the humerus, but in this
yes or
case
no?
it is.
Is it in the exit? Yes or no? No. The
No.
exit is no. How about the carpal tunnel?
No.
No.
No. How about the brachialis?
No.
No.
No. How about the hook of Hammett?
Never
No.
had.
Okay. How about the mid shaft of the humerus?
Yes.
Could be, but not in this case.
Exactly. Okay.
Yeah,
Then
upper.
why not?
Because the triceps reflexes are normal.
There we go. Good one. Okay,
Yeah.
so it's not in the mid shaft of the humerus. Okay. Is it in the surgical?
It's supinator canal.
Yes, this is the answer. Supinator canal. So what they did was, okay, so look, so what they did was they said that there is weakness of extensions of the fingers and thumb, but the tricep reflexes are 2+ and bilaterally symmetrical, meaning that the proximal part of the nerve is intact. So the damage is not in the mid shaft of the humerus. The damage is in the supinator canal. Okay. And the percentage of students who said mid shaft of the humerus is 35%. The percentage of students who said supinator canal was an astonishingly 15%. And 15% supinator canal is the right answer. Are we clear?
Yeah.
Yes.
Yes.
Perfect. Next question. Okay, 1 second. Okay. Next one. Which one is the right answer?
Ovale.
Ovale. Foramen ovale.
Which nerve is damaged?
Mandibular.
Viscery.
Okay, mandibular nerve. Where does it pass through?
On ovale.
So the answer is ovally, foramina ovale. Okay, so the this is a pretty easy one. Is everyone clear?
Yes.
Last question. Okay, this should be an exciting one. We just talked about this. Okay.
Yeah, we solved this one.
We've done this one.
Yeah, we solved.
Yesterday.
Yeah,
yesterday.
shaking.
Oh, okay.
Germinal matrix.
Germinal matrix.
Checking baby.
The answer is the germinal matrix. Okay, the answer is the germinal matrix. Then that's that then. Okay, so that's it. Like this. Okay.
Is germinal matrix lesion the same as shaken baby syndrome?
Yes.
No.
Yes.
No, the shaken it veins.
Not confused.
Shaken baby is a venous. The bridging veins.
What was your question, doctor?
The germinal matrix lesion in intraventricular hemorrhage. Is it happen on shaken baby syndrome also?
Yes.
Or
What is the vessel that is damaged in shaken baby syndrome?
Bridging veins.
Bridging veins. So it's not germinal matrix.
Yes.
Germinal matrix is the one that is responsible for which hematoma. For which hemorrhage? We talked about this.
Yeah.
Ventricular, intraventricular.
Intraparenchymal hemorrhage.
Intraventricular hemorrhage.
Intraventricular or intraparenchymal, right? Isn't that what we discussed?
Yeah.
Yes.
So that's the cause. So germinal matrix. Okay. And for the shaken baby, it's bridging veins. And if you have a bridging vein damage, what type of hemorrhage will your baby have?
Subdural.
Subdural. There you go. Any more questions?
No, this is my confusion last lecture. Thank you so much.
Okay, you are welcome. But so is the confusion averted?
Yes.
Okay, perfect. Thank you so much for asking the question and clearing your confusion. Okay, that's it. Okay, with that being said, thank you so much for doing today's lecture. Okay, we are done with the lecture for today. From tomorrow, we will be starting about the spinal cord lesions, and hopefully by tomorrow we will be done with neurology, and we can start with ophthalmology and otology. Okay, ophthalmology and otology are ear and eyes and ears. Okay, so that's what we will do. Okay, do we have any more questions regarding our lectures, regarding our preparations, anything regarding anything? If you have any question, now is the time to ask. Okay, so
Thank you.
okay, so welcome everyone. Okay, welcome Dr. Khatoon, Dr. Iman, Dr. Adam. Okay, thank you so much for participating. And if you have any friends or colleagues who wants to come and join our lecture, please ask them to come and join so that we can give them a one-day free access so that they can also benefit from these lectures. Okay, so before you leave, guys, before you leave, last thing I want to tell you guys, okay, 4 hours are dedicated to first aid. Okay, and 4 hours should be dedicated to okay, let's make it 3 to 4 hours should be dedicated to UWorld. Okay, 1 to 2 hours for pathoma. Okay, this is how your day should look like if you want to prepare and sit for your exam very soon. 4 hours are with us, 3 hours are for you, 1 or 2 hours is with Dr. Hussein Sattar for watching his videos on pathoma. Okay, and this is what you have to do in order for you to do really well in your exam. And I believe each and every one of you will do exceptionally well in your exam, considering how much you can recall and review in such short period of times and produce all the knowledge. Okay, so so you have my prayers and my luck, each and every one of you. Let me know if there's anything else I can help you guys out with. And if you guys like our lectures and our mentorships, then please give us a proper review or rating on our page on Facebook, so that we can also benefit, so that people can know whether we are good or we are not. Okay, so we would really appreciate that. And thank you so much. And if all is well, if you have any more questions, send us an email and we will try to get back to you. We will try to upload the videos as soon as possible. We are still on the process of uploading videos. And I will share the video for today with each and every one of you. And that's that. Okay, if all is well, I'm going to take my leave right now. Hope you guys have a great day. And thank you. Okay.